This conference will now be recorded.
Well, since I hope everyone is here and we have a lot to cover, we really should begin today's webinar. I really appreciate you all for attending today's webinar. A very good morning, good afternoon, or good evening to one and all present here virtually with me today. Let me introduce myself. My name is Regina Earls from Conference Secretariat at Coalesce Research Group LLC, and I will be available for any of your queries or questions throughout the webinar to help you out technically and organize the webinar successfully. For the next 5 minutes, please allow me to give a brief description about our organization, Coalesce Research Group, and also the further instructions. Coalesce Research Group LLC is very delighted to welcome you all for all the speakers, supporting associations, students, and delegates present virtually with us today. With the aim mark the scientific excellence of facilitation, conversation, sharing knowledge, Coalesce Research Group follows through the objective of setting standards in delivering excellence in the research among the researchers, academicians, and industries. Promulgating the research through conducting events and online webinars from various fields of science, especially from the stream of medicine, science, and engineering, and technology within a short duration, we have succeeded in creating a platform for developing a strong professional network with the people around the world from their respective fields that they haven't connected in a while. As a global scientific event organizer, we help plan and carry out international conferences, meetings, seminars, symposia, and workshops, providing the best delegate experience, excellent networking opportunities, conversation leading to innovation, learning new opportunity, lasting working relationship, and professionalization with the professional around the global network. Just recently, we have also started our own platform for open access pre-reviewed scholarly literature where all the content is freely available without any charge to the reader. We aim to share the new recent advances through scientific publications which help in minimizing the borders and contributing the use of research works of eminent authors, scientists, research scholars, students, etc. around the broad spectrum of medical, clinical, pharma, and engineering scientific disciplines and its subspecialties to promote the ideas which will guide the development and facilitate the use of scientific information and ensure its quality and also will be connecting links between research and scientific community. We are committed in ensuring that our journals are disseminated worldwide so that the researchers are able to access our content wherever and whenever they need it. As being very new to journals, we have coined up some interesting journals and have also formed the editorial board. And we will be very glad if you have any of our today's attendees, the speakers, students, or delegates could extend your support by checking the journals and will be interested in publishing an inaugural issue at any of the journals according to your area of expertise. We will also send an email with all the details about the journals after the webinar, so do take your time to check the website. Finally, I would like to thank the attendees of participants of today's webinar entitled Pain Management and Pain Research and Management and hope you enjoy the webinar and gain the knowledge from the sessions today. We also hope your participants will contribute to new research findings that will lead to new collaborations and research initiatives. Before we start with the sessions, I guess some of you will be new to GoToMeetings app. Let me just explain you the important tools required for the presentation. On the GoToMeetings app or a web page, you can find 4 icons at the bottom center: mic, camera, screen, and mic. Click on that to mute or unmute yourself. I request you all to stay muted while our speakers are presenting their research work so that it does not cause any disturbance to them. Camera, you can use this button to share or unshare the web camera. If you have the option to share the web camera, you can do it and it's completely your choice. Screen, you can use this button to share your screen. This is the main part. During your presentation, after I call your name from my side, I will be making you as a presenter. Then only I will give the permission you will be able to share your screen. So once I make you as a presenter, you can click on the screen button and you will find a pop-up window to share your screen. End button is the fourth icon where you use this to leave the session. On the top center, you can use the options to change your display settings. At the top right corner, you will have 3 icons: people, chat, and settings. In the chat option, you can chat with me or any other participants. For the settings, you can use this button to check for the settings for your speakers and microphone. So as I mentioned, kindly remain muted during the presentation so that the presenters does not get disturbed. And for any questions, you can ask the questions or you can send your questions in the message box too. Well, let's not take much of your time. Finally, I would like to request you all to please give us a brief introduction about yourself before starting the session so that we can know about you virtually. And now move into our first session. The first presenter is Dr. Jainab Umar Amula from Federal University, Nigeria. Hello, Dr. Jainab. Are you ready with your presentation? Hello, Dr. Jainab. Can you please unmute yourself? Okay, Dr.
Yes,
Jainab,
thank you. I'm
I
Zainab
have
Umar
made you as
Abdullahi from.
a presenter. Kindly click on the screen button to share your screen.
Okay, it seems you have to let me do that.
As Doctor, I have made you as a presenter. Just click on the screen button on your GoToMeetings app.
Unfortunately, I can't hear.
Hello, Dr. Jainab. There's a lot of disturbance from your end. Can you please check your audio settings? We are unable to hear your voice clearly.
Trying to do this.
Hello, Dr. Jainab. I hope there's a technical issue from Dr. Jainab's end. Now let's move on to the other presentation. The next presenter is Dr. Soni Sunarosho from Graduate Institute of Biomedical Sciences, China Medical University, Taiwan. Hello, Dr. Soni. Are you ready with your presentation? Hello, Dr. Soni.
Hi, Regina.
Okay, now
Okay.
I'm making you as a presenter. Kindly click on the screen button to share your screen.
Okay, I will try. Wait a few minutes. Hmm. How to share?
Beside the camera button, you will be having the screen button.
Yeah. Okay.
Click on that. Then you will get a
Hmm.
pop-up window. In application, select your PPT
Application
or a
PPT.
screen. You'll get a
Oh,
pop-up window.
it's not work. Wait. Hmm.
You got any pop-up window, Dr. Sani?
Yeah, but it's not work. I think it's a problem about the system preference.
Okay, can you please check your system settings?
Hmm.
Give access for the third-party app to access the file.
You mean that I send my file to you?
Okay, you can send your file to the program manager. We'll be displaying from our end.
Okay. Wait a few minutes. I will send my file. Yes, I already sent to Richard.
Okay, we'll
Right?
be checking you and playing from our end. You can give me 2 minutes.
We received your presentation, so allow me a moment. So I will be sharing my screen now.
Yes, please, Regina. Yeah, perfect. This is my slide.
Yes, is it okay?
Is it okay? Yeah, I
Okay,
will
perfect. So you,
be sharing.
okay then.
Okay. May I start?
Yes, you can start.
Okay. Thank you, Regina. Dear all, good day. I'm Sonish Narsasulistiawan. I'm an anesthesiologist at Dr. Sutomo Hospital. I'm from Surabaya, Indonesia. Now, currently, I'm a doctoral student at the Graduate Institute of Biomedical Science in China Medical University, Taiwan. It's an honor for me to be able to present my research with the title of the effectiveness of preemptive ketamine subdose in reducing intraoperative opioid needs and extubation time with following description. This research was conducted under the supervision of Professor Yung Chen from China Medical University. Slide, next. Next, please. Today's presentation will be divided into five main parts. The first is a brief outline of the most important studies that have been conducted so far. The second is a primary function of the conceptual framework is to lead to hypotheses relevant to the research problem. The third is I'm going to share the strategies, processes for technique utilized in the collection of data or evidence for analysis purpose. The fourth is the explanation of main findings of research interpret the significance of the finding. The last one is the wrapping the ideas as the conclusion. Slide next. The first of main part of this presentation is a background. Slide next. Enhanced recovery after surgery is a new surgery protocol that streamlines patient processes before, during, and after surgeries. It aims to shorten the length of stay for patients and facilitate early mobility and recovery while improving outcomes and patient overall experience. In this research, I am using the ERAS reference by Rivers 2010 and Motov 2015, which emphasize on the decreased total of use of opioid and adequate analgesia. Next. The objective on this research are consists of three analyzing points, as it has been mentioned on the PPT. Analyzing the effectiveness, the association and relationship between preemptive subdose ketamine on the extubation time. It's very important to find out the opioid intraoperative necessity to work to post-operative patient. Next. In this part, I will explain about a conceptual framework, include one or more formal theories in part whole, as well as other concept and empirical findings to show a relationship among these ideas and how they relate the research study in which leads to hypothesis relevant to the research program. Preemptive ketamine and fentanyl preemptive subdose given before surgery will prevent the useless occurrence of peripheral and central sensitization and can last for a long time. This process occurs through the dorsal horn spinal cord to the thalamus and cortex. This process involves inhibition of surgery stress by fentanyl as an opioid and also addition by ketamine in the treatment group. As a result, the stall time will inhibit the onset of acute pain. Yes, this acute pain. Uh, the opioid anesthesia effect and intraoperative administration of additional opioid identified by the Keynote score. The total intraoperative opioid will affect the length of extubation time because the pain experience decrease sensitivity to hypercapnic drive and depercitation. Slide. From the conceptual framework and the research that have been done so far, it was concluded that there is a relationship between preemptive subdose ketamine administration in reducing the need for opioid during surgery and shortening intubation time as the research hypothesis. Slide. Next, please. We can find the detailed research method on this part, which includes the research design, samples, and operational framework of this section. Slide. The single-blind randomized experimental was used as the research design derived from adult patient at the surgery center at Dr. Sutomo Hospital, Surabaya, Indonesia, from March to May 2020 by consecutive random sampling with amount of sample 15 subject in each group. Slide. The criteria sample consists of inclusion criteria and exclusion criteria. The inclusion criteria as the key features used as the target population which conclude typical demographic, uh, clinical, geographic characteristic, uh, the age surgery plan, the use of anesthesia, physical and mentally appropriate. A specific inpatient who underwent the elective surgery at Dr. Sutomo Hospital with post-operative treatment in the room for more than or equal to one time 24-hour willingness to sign an informed consent paper and undergo elective orthopedic surgery and non-cardiac surgery. The next are a set of predefined definition that is used to identify subject who will not be included or who will have to withdraw uh, from a research study after being included, which is called as the exclusion criteria. It is strongly confirmed to exclude the sample who have some specific consideration on the status as the outpatient who has severe heart, liver, and renal disorder, as well as allergic to independent variable and their BMI is more than 30. Next. Uh, in research, variable, in research variable are any characteristic that can pick on different values on the measurement of independent and dependent variable in studies to test cause and effect relationship. The research are using the preemptive ketamine subdose and as the independent variable and total opioid requirement and length of extubation time as the dependent variable. Slide. The result section is a section containing a description about the findings of research, whereas the discussion section interpret the result and provide the significance for the findings. Slide. Okay. The flowchart research subject on the adult patient at surgery center Dr. Sutomo Hospital, Surabaya, Indonesia, especially those for undergoing surgery were divided into two groups. The treatment and control group are consist of 16 subjects for each, with one dropout subject at each group due to the length time of more than 3 hours operation. In this regard, the amount of subject at each treatment and control group are of 15. Slide. The characteristic sample demographic shows the variable of gender, ASA score, operation, duration, age, and body mass index for each control and treatment group. It's shown the comparison between male and female that's slightly different with percentage of 60% male in control group as more than treatment group. As for female, the demographic shows that female percentage is 40%, in the control group is less than treatment group. Meanwhile, for SS score are the same for both of control and treatment groups. Operation duration in minute pace shows that treatment group duration is longer than control group. As for the age, range on sample demographic are about 40.73 and 41.87. For body mass index, the result shows that about 26.54 and 24.53. Right? Next. The comparison of fentanyl amount on both of control and treatment group shows the significant result with the p-value of 0.044. It confirmed that the use of ketamine subdose in the correct amount is effective compared to fentanyl. Slide. Next, please. The slide shows that comparison of extubation time control and treatment group with the range of 7.5 up to 8.5. It showed that difference percentage of on the PSASA1, PSASA2, and PSASA1. The slightly difference among both PSASA is 6%. Slide. The correlation length of extubation time with total fentanyl requirement has a strong relationship and statistically significant with a p-value less than 0.05. Slide. Next. There are two highlight part on this synergy of ketamine and fentanyl. Slide. A synergistic effect of ketamine increase the opioid-induced analgesia duration. Synergistic effect of ketamine on selective morphine or fentanyl. This is opioid signaling via the ERK pathway, and ketamine is more effective in potentiating ERK phosphorylation at lower dose and opioid agonist. Ketamine increased the opioid-induced analgesia duration by modulating opioid signaling so that the opioid receptor remains active for a long time, which is achieved by influencing the desensitization and resensitization time of the opioid receptor signaling. Slide. We have arrived to the last part of our presentation for this research, which provides the output of the work investigation in summarize from as conclusion and state the possible future work research. Slide. The research shows that the use of preemptive ketamine subdose is effective in reducing the need for opioid during surgery and length of extubation time. The conclusion has been made with three key goals. In was in preemptive administration of subdose ketamine, there was a significant difference in the amount of fentanyl administration. Second, in preemptive administration of subdose ketamine, there was a significant difference in extubation time. And the third, the last is the reduced need for intraoperative opioid in this study is significantly accelerated the patient extubation time. Slide. There is a limitation. During the research, some of the limitations have been found and need to be evaluated for future research, which will be suggested on the next slide. The main point on this limitation consists of Q-Nox values on some subject, measurement of the muscle relaxant effect, and ketamine assessment effect. The detailed explanation has been stated on the slide. Okay. Next. The suggestions are taken from the observation and evaluation process during the research. It would be great if these issues could be investigated furthermore. A more sophisticated measure on Measurement on extubation time need to be taken. More references and further studies on the extubation time for correlation mechanism of nicotinamide as an anti-inflammatory and antidepressant. The use of supplement at the end of surgery need to be considered non or excluded. Yes, slide. Okay, and that brings us to the end. I would like to thank you for your time and attention today. I sincerely appreciate it that I have had this opportunity to present to you. Have a great day and stay healthy. Thank you.
Thank you, Dr. Soni Sunarso, for your presentation. So, anyone having any questions? So, no questions from anyone. So, thank you once again for your presence and presentation.
Thank you, Regina.
Yes, thank
Because
you.
I have to breakfast in my time in Taiwan now.
Yes,
I'm
yes.
fasting now
Okay.
as a Muslim.
Yeah,
Thank you all.
definitely. If any, yes, thank you very much.
Thank you very much.
So, moving
See
on
you.
to our next presenter, it's from Dr. Mait Sinos Huate from Gimbanat UPAT MS Spain, and the title of the talk is The Awareness Importance. Hello, Dr. Mait. Hello. Yes, hello, Dr. Matt. We can able to see your screen, but your voice is not audible. We cannot able to hear your voice. Can you please unmute yourself?
Do you hear me now?
Yes, now it is audible. Yes, we can able to see your screen also. Please share.
Okay.
Yes, you can make it a full screen and start presenting.
Thank you very much. I'm sorry for the technical
Okay,
difficulties.
no issue. Yes,
Is
yes,
everything
perfect.
okay? Okay.
Yes.
So thank you for firstly for being here. This is Maite Tenov. I'm physical therapist specialized in mental health field. And I would like to start by reading this quote. Those who do not remember the past are condemned to repeat it. Today's lecture topic is the importance of awareness. Hardly ever have I thought to be speaking with you today about this topic, but as a first-hand witness, I was compelled to speak loud and out. If we are doing science, our decisions should be based on facts, not on beliefs, because they could be prejudicial or beneficial. This could be seen quite simple and clear, but you are going to see that in practice it does not. Who seek shall find, and this should be our motto. However, if we are not aware of what we are looking for, we could be in front of a Picasso, for example, and be blind to see it. Knowledge will be the one that will give us the glasses not to be short sighted when we are looking at. we could be the difference maker if we are aware. I would like to refer to definitions according to the Cambridge Dictionary. Prejudge is to form an opinion about a situation or a person before knowing or considering all the facts. This belief is the feeling of not being able to believe what is true or real. And on the contrary, I would like to spotlight the awareness definition, which is the mental state of knowing about something. Well, this slide is the summary of the next talk. In this case report from 25 specialists from 10 specialties that saw this woman, it was the knowledge of one neurologist and one objective proof redone of the neurophysiological department that clarified the case. Were it not for these two people, guidance and awareness, she would have been bounded to be badly diagnosed and in pain forever. Today's examples will be focused on 9 clinicians' way of thinking, 4 who made the basic mistakes, the reason why I'm here, 2 bias decision examples, and 2 good practice examples who were the key of her start recovery process. Finishing with the contraposition of one physical therapy execution with the same base mistake as the first 4. That was my "this is enough" line. This is Shapson, and confirm the bibliography of facts shown from those 2 previous good physicians. Let's begin. 2015, a fit, healthy 29 woman had a car crash and she was diagnosed with whiplash despite having a decortication posture related by the patient as arriving with a T-Rex position. She did how she arrived, and I was amazed and astonished. And also she referred that she had 4 microfainting times, which were not written in her first medical report. Although we can read in her medical register that the next day she had electrical radiation sensations to hands and feet. As you can see, there was a clear disbelief in her persona at first sight. This could not be real, or this way thinking was that, but symptoms to those who could be aware of them. Let's continue. She was not improving. She was sent to try physical therapy, and it did not work. It was a physical therapy session that led her to emergency because of pain. After this situation, one MRI was asked, and this was written in her report. Very small protrusion at C5, C6, which sleeps into the spinal canal, and a small disc herniation at C6, C7, entering into the spinal canal and partially collapsing the anterior supraarachnoid spaces. I want to think that it was a lack of awareness that happened for not taking those lines into consideration for diagnosis. This is disbelief. So, by Cambridge Dictionary definition, from an opinion about a situation or a person before knowing or considering all the facts, a prejudge was done due to this disbelief. Terrible, but real. I was astonished too. Not only was she given a first step painkillers medication with a dose of 9 for 9 months, and was due to this prejudice believes that she was disbelieved many times too after this medical work, but also she was given too much corticoids, that she had sideburns, brown face, and was she, and not any clinician at all, who saw it and asked, "Is this normal?" As you could be guessing, she was actually having a central Cushing syndrome. So things were not going precisely well. Hence, one neurolog saw her and pointed out in his medical report that she had upper left motor weakness, an exhaustible bilateral clonus, exalted muscular stretch reflexes, especially jaw jerk, tachycardia, and tremor in upper limbs. And consider that three symptoms, jaw jerks, reflexive, tachycardia, and tremor, were medication side effects, but never done any confirmation test, anything. I'm not going to start making what if questions, because those are facts, and this was what was done. For bad clinical thinking, and that took time for her neurological recovery window. But fortunately for her, this neurological report was given to one critical thinker clinician who took into consideration and wrote a new diagnosis: pyramidal syndrome, dependent on exams. Again, unfortunate practice was given because during those new as examination, due to the pain that day she had, and acknowledge of knowing how to get it done, the proof and the procedure, the results were biased, with the terrible consequence of a biased diagnosis. Had those procedures had been well done, she would have had another completely different diagnosis. But the diagnosis was whiplash with functional disease. Furthermore, she had clinic even the morphine, pills, and endovenous lidocaine every 4 months she was taking. This led to a breaking point in her life. Her quality of life was dangerously low. She was not able to be against gravity for 2 hours. Her financial well-being was completely broken. Uh, Thanks to the fact that she was living with her parents, that their quality of environment and personal safety was more or less not touched so much. But she was unemployed. She had before a clinical practice place that she was the chief of it and had 3 months of waiting row for patients. So all those patients she had to send to another practitioners. Obviously, her emotional well-being was touched and lowered, and she lost a lot of her social relationships. However, she was able, due to her skills, to maintain some of them. Well, by annal, until this time, due to the prejudice and disbelief, her life was a huge nightmare. Yet she didn't give in during this harsh pilgrimage, and she searched for another second opinion. Fortunately, she found a good neurosurgeon who, thanks to his knowledge and know-how, was aware of what she could be dealing with, and asked again for a test. But this time, one completely different, knowing how clinician made the neurophysiological tests, and the truth was seen. I quote directly from her results. In summary, the patient presented on physical examination with pyramidalism from all 4 extremities, together with hypoesthesia and paresis in the right extremities. The electrophysiological study shows an alteration in the response of the somatostatic evoked potentials from the lower limb and right upper limb, reflecting a moderate dysfunction of the posterior caudal pathways. for this territory. It also presents a suspended thermoalgesic alteration from upper cervical to thoracic levels, T7, T8, that could correspond to an added centromedullary syndrome. Heavy, isn't? Well, the elephant in the room appeared suddenly. Also, we can read from her medical report that she presented a 70% of brainstem disability index and urinary malfunction and more. Heavy. Mm? Really, but real, she presented a tethered core too, and after surgery was preceded the neurosurgeon prescribed Mulroney protocol based on physical therapy for the craniocervical instability. Crystal clear. Physical therapy was the next step. As her physical therapy didn't know how to do the Mulroney protocol, she started reading and doing the first exercises of the book on her own. With the protocol in my hand, I took the liberty to teach a relative of hers who was retired the basic lines of for that at least she could do them with a bit of safety. Besides doing the active movement on her own, she looked for a physical therapist. I thought she was in good hands. She has, that physical therapist, he has the book, the guidelines, but again, due to his, I want to believe that was a lack of importance, awareness, or disbelief, call it as you want, due to this physical therapy session without the protocol and surgeon's guidance taken, a movement therapy session was done and a relapse was obtained. Before that session, she had 2 months of not having any tramadol or morphine derived in her blood. She was clean. But after that physical therapy, the consequence edema that it produced was so heavy that it took more or less a month to get recovered from that session and get to the before active physical therapy session point. This case seems like a Pride and Prejudice book, isn't? In the names of physical therapy, I asked her for forgiveness because it was clear that she was going well, and this has been the breaking point. Her situation now, she is almost taking no tramadol, but she's taking a little bit too. She's doing active movements again, but on her own, and she is fighting against the situation to find a good physical therapist too. To be honest, after having seen the consequences of that active movement session, my jaw dropped, and I felt ashamed as a clinician. That could have been avoided if he had followed the book's instructions. So it must be said that she suffered an unnecessary disbelief. What I admire is her determination and resilience. Her psycho that worked with her is doing an outstanding management. That's for sure. In the light of aforementioned, small things matter. It's better to verify instead to do presumptuous thinking. And congratulations for being here because you are updating and now you are aware of what our ego could have huge consequences and what our ego could do. Moreover, we need to follow facts. This is science, health science, isn't it? Well, thank you for having the will to be updating this way because this is a way to excellence in practice. To conclude, as I told you, this slide summarizes all that has been said. Being aware of possibilities and the patient you are with, with updated knowledge as you have now. Asking for looking over the exams and looking for the truth is the way that I could foresee that is the way to successful treatment. Who seek shall find. We need to be aware that our ego should be put aside. This is health science. Do not wait till you are 100% sure of what the betting theme is. I'm looking forward to hearing the next lecture to know what I should be aware of in my searching. Thanks for listening. If you have any question or any item that you would like to ask, I'm gladly happy to listen to them. Thank you.
Yes, thank you. Thank you, Dr. Matt Sinos, for your presentation. So, anyone having any questions? Okay, no questions from anyone. Thank you once again for your presence and presentation.
Thank you very much for having this opportunity.
Thank you. So our next presenter is Dr. Zainab Umar Abdullahi from Federal University, Datsinma, Nigeria. And the title of the talk is Trypanocidal Effects of Snake Venom Fractions. Hello, Dr. Zainab. Hello, Dr. Zainab. Your voice is not audible.
Are you talking to me?
Yes,
How
yes,
about
now. Okay.
now?
Excuse me. Yeah, sorry. Yes?
Yes, so I will share my screen with your presentation. And when you have to change the slide, just let me know, okay?
I first went okay.
I'm sorry, your voice is not properly audible.
Until now.
There is disturbance, like,
This entity.
no, Dr. Zainab, there is a disturbance, like we cannot able to hear your voice
So
properly.
challenging. About hi,
Hello?
you with me?
Yes, yes, I'm going to share my screen. Just a minute. Yeah, is it visible? But your voice is not properly
About
audible.
I'm having network. Can you hear me now?
I think you need to check with your speaker phone. It is the problem with your speaker connection, not the network, because as we can see, you have joined through webcam and it is working properly. Please check your headphones or speaker phones which you are connected to speak. It is the problem with that.
Hi.
Okay, there is some network issue due to which Dr. Zenab cannot able to present. So So I would request Dr. Serap to present her presentation. Is it possible? Hello, Dr. Serap.
Hello, can you hear me?
Yeah, yes. Can you able to present now because we have contacted the speakers, but they
Yes,
need time.
with a pleasure.
Okay. Yeah, thank you very much. So I'm going to make you the presenter. Yes. So our next presenter is Dr. Serap Bills from Sukurova University, Turkey, and the title of the talk is The Case of Sagittal Sinus Thrombosis After the First of Intrarectal Nusiresin Treatment. So
Is
we can
my
able to
screen
see, yes,
visible?
yes. You can
It is
play from the
visible.
beginning, yeah,
Yes, okay.
and make it a full screen.
Uh, just a minute.
Yes, perfect. Please continue.
Uh, just I okay. I want to present. Hi everyone. I want to present a case of sagittal sinus thrombosis after the first dose of intrathecal nusinersen treatment, and it was a case of presentation that we had in Çukurova University in Turkey. I can go on. Okay, it's a bit slow. Spinal muscular atrophy is a progressive autosomal recessive motor neuron diseases that occurs due to loss in SMN1 gene. Nusinersen is antisense oligonucleotide that produces an effect by increasing SMN protein production. Despite the studies that demonstrated improved motor function and milestones in infants and children after intrathecal nusinersen treatment, side effects were also reported. Our aim in this case presentation to report an experience with 16 years old boy with spinal muscular atrophy that experienced sagittal sinus thrombosis 5 days after the first dose of intrathecal nusinersen treatment. A 16 years old boy who had difficulty in walking after 6 years, fasciculation in tongue muscle, absence of deep tender reflexes, was diagnosed genetically and clinically as a spinal muscular atrophy type 3. He was the fourth child of consanguineous parents. All the other siblings were healthy. The pregnancy was uneventful. He experienced low muscle tone at 6 years old and difficulty in running and climbing stairs. There was a homozygous deletion in 5q-SMN1 and the copy number of SMN2 was a 3. A complete blood count and biochemical analysis were normal. The patient didn't have non-history of thrombosis or bleeding. There was no history of any cerebrovascular accident in the family. After 5 days of receiving the first dose of intrathecal nusinersen, The patient experienced severe headache and pain, nausea, vomiting, epistaxis, and gradually increased neck stiffness. On physical examination, the measured temperature was 36.7. He was conscious and expressed severe neck stiffness. No kerning ambrosia was seen. Cranial nerve examination and cerebellar tests were normal. Baby's Q reflex was plantar. There was a papilledema of the optic disc on ophthalmic examination. On laboratory tests, acute phase reactant were normal. On lumbar puncture, the cerebrospinal foot pressure was 40 millimeter. Water, protein, and glucose were 39 and 67 milligram uh, deciliter, and normal cell accounts were found. Magnetic resonance image (MRI) showed the thrombosis in the superior sagittal sinus and pachymeningeal enhancement. Venography showed following defect. Here in this coronal sequence, 16 years old patient with SMA, cerebral MRI neuroimaging shows thrombosis in the superior sagittal sinus and pachymeningeal enhancement. CBC and homocysteine B12 folate serological panel S3, S4, ANA, anti-DNA, APTT, PT, and INR were normal. In the thrombotic factor examination, no abnormality was found except heterozygous polymorphism in the MTHFR gene, 6C6770. Enoxaparin was started, nusinersen treatment was stopped and never planned again. Discussion despite the beneficial effects of nusinersen on motor function and milestones in infant and young children, its benefit in adult are still unclear. Besides intrathecal nusinersen, side effects are reported. The effect and adverse effects of this drug have not been revealed completely. Some reported side effects were related to intrathecal administration rather than the drug itself, and some effects are related to the drug itself, which can be mild, like fever and vomiting. Serious side effects like thrombocytosis, epistaxis, and bleeding due to clotting disorders, decreased blood platelet could also be seen. Our patient experienced signs and symptoms of increased intracranial pressure and a sagittal sinus thrombosis 5 days after the first dose of intrathecal nusinersen treatment and increased intracranial pressure. Cerebrosinal venous thrombosis is a disease that can be seen in all age groups, different clinical findings, and mostly with good prognosis. The most important non-etiologies are pregnancy, oral contraceptive drug, systemic inflammatory diseases, malignancy, coagulation disorders, and hematological diseases. MTHFR gene polymorphism, C6770, A 1298C, presenting a risk factor alone or though homocysteine level is controversial. The incidence of this polymorphism in healthy individuals are also being reported. In our case, whether cerebral sinus vein thrombosis occurrences due to the nusinersen or due to the MTHFR mutation is still unclear. This study cannot make causal interference on the relation between nusinersen and MTHFR mutation to the absence of a previous stroke history and occurrence the thrombosis after only the first dose of intrathecal nusinersen made us think the strong relationship between the drug and sagittal sinus thrombosis as a causative factor. In one study on 15 patients who had cerebral vein thrombosis, two were determined to carry homozygous mutation in MTHFR mutation. 7 out of 15 patients investigated for MTHFR mutation were determined to have homozygous, and one of them had heterozygous, and one of them had homozygous mutation. These mutations are clinically relevant if they cause hyperhomocystinemia. Our patient homocysteine level was a 3.1 milligram deciliter, which was normal, and he did not have any until the first intrathecal dose of nusinersen treatment, which, due to the best of our knowledge, is the first SMA patient to develop stroke after nusinersen treatment. So, as a conclusion, the adverse effects of nusinersen are still unknown. Increased intracranial pressure are manifestations such as a prolonged headache, pain, nausea, and vomiting after intrathecal nusinersen treatment should be taken seriously, and possibility of cerebrosinus vein thrombosis should be kept in mind. Thank you so much. Am I audible?
Yes, hello. Yes, thank you, Dr. Sarab, for your presentation.
Yes.
Yes, so anyone having any questions? So, no questions from anyone. Thank you once again for your presence and presentation.
Thank you.
Yes. So, hello, Dr. Zainab. Are you ready now?
Mm.
Can you able to give the presentation?
Yes,
Yes, so
yes.
I'm
Can you
going
hear
to
me?
share my, yes, now it is perfect. I'm going to share my screen. Just a minute.
Okay,
Okay.
okay. I'm with you.
Yes. Yeah, can you able to see my screen? Yes,
Not
so
yet. Yes, now I can see the screen.
please start presenting. Yes, you can start.
Okay, thank you for letting me in. And first, I want to apologize for issues beyond my control. I experienced a very, very poor network connection here, so I couldn't join at the right time. So I apologize to the audience and to the host. Yes, the presentation as seen on the screen is trypanocidal effects of snake venom fractions. Please, are you with me? Can you hear me?
Yes. Yeah, we can able to
Hi, is it
hear. Yes.
audible enough?
Yeah, it is audible. You when I have to change the slide, just let me know. I will do that.
So trypanocidal effects of snake venom. Okay, trypanocidal effects of snake venom fractions. By trypanocidal effects here, we're gonna discuss about the therapeutic potential of snake venom fractions as potential therapeutic agents against the lingering protozoal disease called trypanosomiasis. This study was carried out to unravel the potential of snake venom fractions as potential therapeutic agents against trypanosomiasis. Next slide, please. Now, my content contains first a background, and then snake venom fractions, and then their trypanocidal effects, then a summary of what is said, and then references. Now, first the background. Next slide, please. Trypanosomiasis as a serious public health threat refer to the various diseases, protozoal diseases caused by trypanosomes. This include the African animal trypanosomiasis, the human African trypanosomiasis, as well as the American trypanosomiasis caused by Trypanosoma brucei rhodesiense, Trypanosoma brucei congolense, and Trypanosoma brucei. For quite a time, this has been a serious public health threat. In 1998, about 40,000 cases were reported of the human trypanosomiasis, and an estimate of 300,000 cases were reported to be undiagnosed and hence untreated. In 2009, anyways, After continued control efforts, the number of cases declined below 10,000, and this continued until now, with new cases of about 992 and 663 in 2019 and 2020, respectively. However, still yet, an estimate of about 55 million people at risk has been reported, with 3 million people at moderate and high risk. About the epidemiological control of trypanosomiasis, there has been difficulties in achieving control, first due to vector and the reservoir control, and on the part of the parasite due to possession of what is called variant surface glycoproteins. Next slide, please. As such, there is need to unravel other trypanocidal agents, especially from natural compounds. And the use of snake venoms as therapeutic agents is an interesting concept. Snake venoms are complex compositions of toxic and pharmacologically active proteins and peptides. Of this large number or arrays of proteins and peptides, about 50 to 100 have been put into the dominant families and the second families, consisting of multiple proteins and peptide isoforms. Next slide, please. Next slide. So now the snake venom fractions, and they are grouping into the dominant families and the second families, and then they are effect. Now, of the snake venom fractions that belong to the dominant families include the secreted phospholipases, known as the plateaus, the snake venom metalloproteases, that's the SBMPs, snake venom serine proteases, that is the SVSPs, and then the three-finger toxins. Whereas members of the secondary families include the cysteine-rich secreted proteins, that's the L-amino acid oxidase, that's the LAOs, the Kunis peptides, the C-type lectin, the disintegrins, and the natriuretic peptides. The pharmacological potential of snake venom fractions has been grouped into three. They will either confer hemotoxic effect, neurotoxic effect, or cytotoxic effect. And we're going to see that in the next slide. Next, please. Next slide. Now, regarding the triponcidal effect of snake venom fractions, from the result of our systematic review, the previous slide, please. Previous slide. Previous slide. Previous slide. Previous slide, please. Yes, this. Result of our systematic review titled next slide, please. Result of our systematic review titled The Antiprotozoal Effect of Snake Venom and Their Fractions, a systematic review, showed that although a number of studies has been done to ascertain the triponocidal effects of snake venom fractions, have been geared towards identifying this on two issues of the types, as well as the African trypanosomiasis, as well as Trypanosoma cruzi, which is responsible for the American trypanosomiasis, otherwise known as the from this, from Botrops atrox was extracted and tried on Trypanosoma cruzi. Equally, same L-amino acid oxidase from Lachis muta, B. jaracusu, Calolesma rodostoma, and B. jararaca were extracted respectively and tried on Trypanosoma cruzi, which is the causative agent of the American trypanosomiasis, also known as the Chagas disease. And all these were reported to show trypanocidal effect on Trypanosoma cruzi, making them potential therapeutic agents against this disease. Also, plateaus, second on the bullet, which belongs to the dominant family, was extracted from Botrytis asper, Botrytis maragioensis, and both showed activity against Trypanosoma cruzi. Catalysidine, which is part of the secondary families also from Crotalus diricus terrificus, was extracted and tried on T. cruzi, and it showed killing effect. Equally, spermine, which also belongs to the secondary families of the snake venom fractions, was extracted. Hi, are you with me?
Yes, yes.
The slide is off. I can't see my slide.
Yeah. Now it is okay?
So yeah, spermine from Aristocopus macmahoni was also extracted, but this time not tried on Trypanosoma cruzi, but on Trypanosoma brucei, which is responsible for the African animal trypanosomiasis as well as the human African trypanosomiasis, and it showed trypanocidal effect. Similarly, batroxycidine from B. atrox was also extracted and tried on T. cruzi, and it showed autophagy, which shows it has potential as a therapeutic agent against T. cruzi. Then CRIPS, that is the cysteine-rich secreted protein, which belongs to the secondary family also from Crotalus viridis, showed activity against T. cruzi. Next slide, please. Next slide. Next slide. So this killing effect presented by the various snake venom fractions extracted from various snake species presents their potential as therapeutic agent against the lingering trypanosomiasis. In summary, it could be deduced that most of the studies carried out were on Trypanosoma cruzi, the causative agent of the American trypanosomiasis, with most studies trying L-amino acid oxidase, which is a snake venom fraction belonging to the secondary family. Similarly, most of the snake venom fractions were from snakes belonging to the Viperidae family, also known as the vipers. As a recommendation, there is need to further research studies on the therapeutic potential of other fractions that have not been studied, and also to put other trypanosome species under trial. Next slide, please. Next slide, please. These are some of the references. Next slide, please. I wish to acknowledge my collaborators in this research, Associate Prof. Dahahe from Hong Kong Polytechnic University, Dr. Salihu Sabiu Musa from same university, and Dr. Umar Mbello from Yobe University Teaching Hospital, Damaturu, Nigeria. Next slide, please. Thank you for listening.
Thank you, Dr. Zainab, for your presentation. So anyone having any questions? Okay, no questions. So thank you once again for your presence and presentation.
Oh, thank you too, and I apologize for the disappointment due to network.
Yeah, and no, not an issue. Thank you very much. Yes,
Yes.
so our next presenter is Dr. Anwar ul Huda from Security Forces Hospital, Saudi Arabia. And the title of the talk is the use of PENG block in hip surgeries in associated with significant reduction in opioid consumption, lesser motor block, and better patient satisfaction, a meta-analysis. Hello, Dr. Anwar.
Yeah, I can hear you. Can you
Yes,
please
so
let me?
you are the presenter now. Please share your screen with us.
Um, can you hear me?
Yes, yes, I'm audible. So, is there any issue?
Yeah, I mean, I'm using Mac. I don't know whether I
Yeah,
need to
did you
go to
give
this.
permissions in your system preferences?
Yeah, it is there.
Okay, so
It's not
what you can do is once you log out from the session and again try to join.
okay.
Yeah, once you close the session,
Leave it again. Leave and then join again. You mean?
yeah, join again.
In the system preference, what I need to do?
There you will find an option to give the access to screen sharing.
I did it before. Not
Yeah, for that reason only, once you log out and again try to
sure.
log in, then definitely it will work.
Okay, thank you.
Okay. So we will wait for a few more minutes so that Dr. Anwar will join the program, and in the meanwhile I will contact to him.
Hello, can you hear me?
Yes, yes. So I'm going to make you the presenter. Yeah, you can try once now. Yeah, is there still an issue?
Yeah, I mean, it's getting the system
Okay,
preferences.
so what you can do is you just send your presentation to Program Manager. I will share my screen and you can give the explanation.
So I'll just send to the same WhatsApp group.
Yeah, you can send in the WhatsApp as well, no issue.
Okay.
So once you send the presentation, just let me know. I will take it from the Program Manager.
Yeah, I think should have gone now.
Yes, so allow me a few moments. I will take it from him.
So from his screen share now. Should be still the same. System preferences.
Yes, I got the presentation, so I will share my screen now. So just let me know whether it is visible or not. Yeah, is it visible properly?
Yeah, I can see that. That's fine.
Yeah, so once you need to change the slide, just let me know. I will do that for you.
Okay, fine. Thank you very much for giving me the opportunity to present here. Um, my name is Anwar, and the topic I'm presenting here today is regarding a meta-analysis which we did very recently, and it's still in the process of publication. The topic is the use of Planck block in the hip surgeries is associated with significant reduction in the opioid consumption, lesser motor block, and better patient satisfaction. Next, please. So one of the co-investigator in this study is Dr. Hasham. Next. And I declare no conflict of interest and no disclosure. Next, please. So this will be the roadmap for my presentation. I'll start with introduction of the topic, then objective of my study, We'll discuss about methodology and results, then a bit of discussion, finally some limitations of the study, and then conclusion. Next, please. So hip surgeries are generally quite demanding in terms of use of regional anesthesia block. And the reason is because hip joint has a very complex innervation. Depends on the lateral cutaneous nerve, femoral nerve, and the obturator nerve. And obviously, the different ultrasound guided peripheral nerve blocks have been used for the hip pain, either for the hip analgesia just after the fracture or after the surgery or before the surgery. And they include fascia iliaca block, femoral nerve block, lumbar plexus block, and they are the most commonly used ones, and they are mainly used for their opioid sparing effect. Next, please. No, before this. Previous, yeah. So, but the problem with these blocks are their obturator nerve and the accessory obturator nerve are usually spared, and that result in inadequate pain control. But at the same time, the quadricep muscle strength is reduced, which is again one of the drawback of these blocks. Next, please. So Peng block, which we did use in this our meta-analysis, it's an innovative ultrasound-guided nerve block, which was initially described in 2018 by Jeroen Arango et al. And since then, it has been successfully been utilized as an optional regional anesthesia block for hip surgeries. And the advantage is obviously it doesn't affect the motor function. And several studies have been conducted about effectiveness of Peng block in pain control of hip fracture. Next, please. So as you can see in this diagram, this is the ultrasound picture, and basically probe is placed on the inguinal region, and the nerve, the local anesthesia is infiltrated between the hip joint and the iliopsoas muscle. Next, please. Previously, if you look at the literature, we could only found one review that was based only on case reports and case series. But since then, there have been few randomized controlled trial. And that was the reason why we selected this systematic review and meta-analysis for our study. Next, please. So the aim of the study was to assess the impact of Peng block on analgesia and opioid use after hip surgeries compared with other blocks or no blocks. Next, please. Talking about the methodology, it was a systematic review of the scientific literature and primarily addressing the use of Peng block for hip surgeries. We used Prisma guidelines. The database we used Medline and Science Direct, and it was prospectively enrolled in the Prospero database. Next, please. All the included studies reported opioid use, pain control after surgery, and side effects among patients who received Peng block for hip surgery. And all approaches for the performing the Peng block, we accepted it in this study. Next, please. A pre-specified table was used to extract all the reference data, and we extracted information like study general details and outcomes, the quantitative data, and the qualitative data. Next, please. Risk of bias was assessed by ROP2, which is sort of a standard method for assessment, or tool for assessment, and we use review manager software, RevMan, for Mac version 5.4, and we assess the heterogeneity of the data by I-square. Next, please. So what we included in this meta-analysis were the pain assessment results, then 24-hour opioid consumption. The data were pooled, and the side effects were also pooled without a time limit. We measured the standardized mean difference for the continuous data. For the dichotomous data, we use odds ratio. A random effect model was used because to avoid the heterogeneity during our data, and the p-value of equal or less than 0.05 was set as significant level. Next, please. So coming to the result now, you can see the search strategy as we use for the midline. We initially put Pang block, which gave us 3,186 studies. So in total, when we use our strategy, the total of 66 studies were identified. Next, please. And you can see the flow diagram in this one. Out of 66, we after exempting of the reviews, letters, case reports, because we only included randomized controlled trial with specific outcomes, and in total we included 6 randomized controlled trial in this meta-analysis. Next, please. So the results, as you can see, the first pool analysis, that was forest plot for the time to first rescue analgesia, and we can see that the difference is 3.82 milligram morphine equivalent, prolongation of the first rescue analgesia request on patients receiving the Pang block, which was found to be statistically significant. Next, please. Next. Yeah. So if you see the opioid consumption in this one, again, we found a significant reduction in the opioid consumption with the use of Pang block. Obviously, the number in this one is a standard mean difference, so you cannot get the complete idea. But we'll tell in later that how much was the reduction. But this result was found to be statistically significant, as you can see in this forest plot. Next one, please. Regarding the post-operative satisfaction, based on 2 studies for this meta-analysis, we found it statistically significant with the odds ratio of 4.58 and p-value of 0.02. Next, please. Again, the motor block, which is, again, as we mentioned in the introduction, that one of the problems with the previous blocks are that they may cause a motor block, which again is not good for the physiotherapy post-operatively. The advantage of this block, as you can see in this the very highly significant p-value with a lesser motor block with the use of Pang block. Next, please. Although at the same time in an analysis based on the pooling results, the pain scores were not found to be statistically significant between the Pang block and the other cohorts in the post-anesthesia care unit at 6 hours, 12 hours, 24 hours, and you can see the values are p-values 0.59, 0.10, 0.18. So obviously it was not found to be statistically significant. Next, please. As far as the nausea and vomiting, which is one of the side effect post-operatively based mostly on the because of the opioid use and also use of the anesthesia. But the difference was not found to be statistically significant, with the incidence of the post-op nausea vomiting in the Pang group was 12.9 versus 20.3 in the other groups. Next, please. So as you can see, Ellis et al. And the Fahy et al., they shown that peripheral nerve block can enhance the dynamic pain control, hasten the recovery, and decrease the usage of opioids and associated unfavorable outcomes. Cochrane review done by the GOE demonstrated that regional anesthesia use can reduce the post-operative complication risk and also resulted in earlier mobilization and decreased opioid consumption in hip fractures. Next, please. And according to the review by Bono et al., the most of the Pang blocks were performed for analgesia related to hip. And the Giron et al. Also found a 7-point reduction in pain score after Pang block in hip fractures. Almost similar results were demonstrated in other case series as well. So you have seen that, we can see that in the previous studies, there was significant reduction in the pain score. Next, please. Goa et al. Showed a 3.4-point reduction in the pain score by the use of the nerve block in the hip fractures. The Lim et al. Also in a retrospective review shown a 6-hourly post-operative pain control was significantly lower compared to the cohort group, if you compare it with the Pang group specifically. However, insignificant difference was found in the pain score at 12 and 24 hours post-operatively. So early pain control was good in this study, but not later on. Next, please. On the other hand, in our meta-analysis, it was not found to be statistically significant, the pain score, in the post anesthesia care unit at 6 hours, 24 hours, and 24 hours post-operatively. Next, please. Coming to the opioid consumption, if you look at the literature, Bono et al. In their review described that PANG block as an opioid-sparing analgesic strategy for hip analgesia. Our meta-analysis also demonstrated a significant decrease in opioid consumption, and as we mentioned previously in the result, that there was 4.92 milligram equivalent dose of morphine mean difference or decrease in the opioid consumption post-operatively with the use of with the use of PEG block, which was found to be statistically significant with p-value of 0.05. Although previously Lim et al. Didn't show any significant difference in opioid consumption with the use of peripheral nerve blocks. Next, please. Coming to the quadriceps muscle power, Giron et al. Demonstrated the better preservation of quadriceps muscle power in postoperative time with the use of PANG block when compared with the femoral nerve block. And this finding was also found in the study by Short et al. As well. Next, please. Although some studies mention a complete femoral nerve and obturator nerve block after PANG, and as you can also see in the Yu et al., in their study, they have mentioned 2 cases of quadriceps muscle weakness. But our meta-analysis highlighted a significantly decreased motor block of quadriceps muscle with the use of PANG block compared to the other block, again, which is again one of the advantageous effect of the PANG block. Next, please. So, coming to the limitation of the study, firstly, I will say that the dosage and the timings of PEG blocks were different. By dosage, I mean that there was not standardized dosing in different studies. Some used 15 ml of ropivacaine, some used bupivacaine. Similarly, the timing of the PEG block was also different. So although most of the studies have done it intraoperatively, either before induction or after induction. One of the study actually used a PEG block in the recovery. But in all the studies, obviously the PEG block was used, but at different timings. So this is one of the limitation of our study. Secondly, the type of anesthesia used in different studies was also different. Like half of the studies used general anesthesia along with the block, and other halves used spinal or combined spinal epidural with the nerve block. Different comparison groups were also used, like PEG block was in use in one group with fascia iliaca block, with the femoral nerve block, with no control at all. So this is again one of the limitation for the study. None of the study also reported any readmission or prolonged hospital stays due to inadequate analgesia, nausea, vomiting. This is again one of the important effect which if we talk about the ERAS or the enhanced recovery after anesthesia or after surgery, then it's important to look at these outcomes as well, like readmissions or prolonged hospital stays. Although none of the studies have mentioned this one, so again, this I would consider as a one of the limitation of our study. Next, please. So, in conclusion, we can say that PEG block can significantly reduce 24-hour opioid consumption after hip surgery. And also the time to first request of analgesia is also prolonged with the use of PEG block, and we can see is about 3 hours, and then lesser risk of motor block, and hence better physiotherapy, which is again one of the significant advantage of after this surgery, because this surgery needs ambulation as early as possible, and if we have lesser motor block, then our physiotherapy colleagues can help the patient much better and much quicker. PEG block is also associated with better patient satisfaction, which is again one of the great outcome out of this study. So this is all I have to say about my meta-analysis. Thank you very much. If anyone have any question.
Thank you, Dr. Anwar, for your presentation. So anyone have any questions? So there is no question, but there is a message from Dr. Maid Konas that congratulations to Dr. Anwar. She has written the message.
Okay, thank you.
Yes, thank you very much for your presence and presentation.
Thank you.
So yes, so by this we came to by after this we can take the lunch break, and now it is 1 o'clock. That is 13. We'll back at 13:30. That is at 1:30, and we'll continue with our sessions. Thank you, and please stay connected.
This conference will now be recorded.
Thank you all for staying connected with us. Now we can resume our sessions after the lunch break. And our first talk will be from Dr. Rita Rufu Carcerelli from Pereira Rosal Hospital, Uruguay. Hello, Dr. Rita. Hello, Dr. Rita. Am I audible to you?
I'm here.
So will you please share your screen with us? I already gave you permission to share the screen.
Yes. Right. I don't found the presentation. Please.
Yeah, I mean in your screen you cannot able to find the presentation.
Well, yes.
Yeah.
Can you see?
No, it's not visible. Please, did you click on the share button?
Where?
That is the third icon on your screen. My camera and share. Click on that. Yes, now it is visible properly.
Well.
You can make it a full screen.
Well.
In the below, you can click on the last option. That is right side, bottom of the screen, right side.
Okay. Okay.
Yeah, go to bottom right.
Yes. And I don't.
No, bottom of the screen.
Yes,
Not
but
below.
I can't. I can't.
Yeah, otherwise click on F5, F5. Yes,
Now
perfect.
is.
Yes, please start the
Well.
presentation.
Thank you. Thank you. I'm Rita Rufo from Uruguay. This study is about neonatal pain, about pending issues in hospitalized neonates in intensive care. The neonatal pain control group defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Neonatal pain extends far beyond conventional definitions and defines stress and alteration of the dynamic balance between a newborn and its environment that results in a physiological response of the newborn. The objective of this study is to raise the awareness of promote improvements in the approach to pain in neonates and reflect on pending issues in the pain management in neonates. The material and methods is a bibliographic review, included a period since 2016 to 2022, and we explore the results based on 10 questions, and we selected 20 studies from the research. What are the difficulties in recognizing it was the first question. And Guillermina Chata from Argentina showed us 10 reasons. The belief that they can't feel pain in the same intensity, the neonate doesn't express pain, there are no specific signs of pain, professionals don't receive training, poor use of objectives instruments, afraid about opiate side effects or addiction, non-pharmacological care is considered a placebo, the use of analgesia according to pain, the parents' opinion is not valued, and lack of knowledge regarding the impact of pain on the neurodevelopment. What is the best monitoring method? No explicit evidence can be obtained to support the use of one proper scale in pain assessment. Some tools, including now the nursing perceptions. Although brain-oriented technologies have been explored, none are currently ready for clinical implementation. Newborn infant parasympathetic evaluation technology could be a better measure than heart rate. A systematic review showed use of non-validated pain scale in some studies. What is the role of parents? The recommendation for procedural pain prevention involve pharmacologic and non-pharmacologic treatment, parents, and interprofessional collaboration. Modern neonatal care is family-centered and includes, with proper counseling and information, parental presence in the neonatal unit, parental involvement in care procedures, and parental involvement in pain management. What does the neurodevelopment protection program provide? It could facilitate proper control management of pain because minimize or limit unnecessary painful stimuli, encourage the presence and collaboration of parents, and maternal kangaroo care is a pain relieving intervention. How the neonatal pain guidelines can be improved? The standard guidelines for neonatal pain management based on the available high quality evidence will help neonatal caregivers. The critical step for developing the guideline are definition for guideline scope, establishment of guideline work groups, selection of the clinical questions, performance of systematic reviews, grading the quality of the body of evidence, and formulating recommendations. The consensus. Guidelines is intended to cover 10 to 20 clinical questions about 4 categories. What are the principles of neonatal pain management? How to accurately assess newborn pain? Do pain measurement instruments detect the effect of pain-reducing intervention in neonates? And this intervention produce significant improvement in the pain experience and other critical outcomes. Managing pain requires a multifaceted approach, 6 elements to be taken into account when performing a painful procedure: planning the procedure, collaboration and involving the family, environment measures, pain assessment, choice of analgesia, and documentation in the patient's record. Parents receive written information on procedural pain management to improve involvement during painful procedures. Is sedation well valued? Well, we found that the neonatal pain agitation and sedation scale is a good tool for sedation, but is not is reliable for many, but not for all neonatal subpopulations. What are the best studies that are in neonates? We found a study that included 84 studies and showed that morphine and fentanyl are the drug most used in neonates. Opioids are the mainstay for the effective treatment of moderate to severe pain across all age, including neonates. The most used non-opioid analgesic to manage pain in children, including neonates, is acetaminophen, And a study showed that although it reduced acute pain, sucrose didn't reduce brain effects. Implementation of non-pharmacologic modalities during minor procedures increased significantly by 2019. What complications appear in chronic use of pain drugs? We found physical dependence in full-term infants occur following sedation over 5 days. Infants with surgical disease receive escalating doses of morphine and midazolam when administered over 30 days. A positive association between length of sedation and weaning period was found in both respiratory and surgical disease groups, while length of sedation is related to hospital stay for the respiratory group, but not for surgical disease group. When is off-label use ethical? We found that the Europe pediatric regulation has had a very positive impact on pediatric drug development, more medicine for children, and develop more information on the pediatric use of medicines. What is expected in the future? Some issues are the prevention of pain in neonates should be the goal of healthcare professionals who work with neonates. Increased efforts are needed to promote consistent pain assessment and management to ensure optimal outcomes for vulnerable and risk neonates. More training is needed to improve NICU staff competence in using pain scales. A future pharmacological direction should lead to standardized sedation protocols and evaluate patient cognitive outcomes. As conclusions, the set of recommendations for procedural pain prevention needs to involve not only pharmacologic and non-pharmacologic pain treatment, but also parent and interprofessional collaboration. Each neonatal intensive care unit should choose a limited number of tools for pain assessment in different population, context, and type of pain. There is a need to improve the methodological quality of guidelines for procedural pain in newborns. The subject requires continuous review and investigation and is ethically inappropriate to use invalidate scales in research. Thank you.
Thank you, Dr. Rita, for your presentation. So, any questions from anyone? So, no questions. Thank you once again for your presence and presentation.
Thank you very much.
Yes. So, our next presenter is Dr. Huang Wei Ling from Medical Acupuncture and Pain Management Clinic from Brazil. And the title of the talk is Energy Alterations in Patients with Fibromyalgia and How Can We Treat Without Using Anti-Inflammatory Medications. Hello, Dr. Huang Wei Ling.
Can you hear me?
Yes, so you are the presenter now. Please share your screen. Okay, you have joined with another name, so I will give you this. Yes. Yeah. Please share your screen with us. Yes, we can able to see your screen. Yes, we can able to see your presentation. You can make it a full screen.
Hi.
Yes,
Can I begin my presentation?
Yes, you can begin.
Yeah. Good morning, good afternoon, or good evening to everyone. My name is Juan Wailinha. I'm a medical doctor from Brazil. I'm very happy to be here in this conference to share this study entitled Energy Alterations in Patients with Fibromyalgia and How Can We Treat Without Using Anti-Inflammatory Medications. I have six specialties. The first specialty is infectious disease, but for the last 25 years, I've been working with traditional Chinese medicine in my own clinic in Brazil. So I will show this presentation according to the TCM point of view. Until today, doctors do not know the cause of fibromyalgia, but it most likely involves, according to Western medicine, genetics, infection, physical or emotional factors. And the treatment, according to Western medicine, is based on pain relief, such as the use of antidepressant and in some cases associated with unsavory medications. And normally, a patient with fibromyalgia will present normal laboratory exams, even with excruciating amount of pains. And this presentation will be following Hippocrates' thoughts that said that foolish the doctor who despises the knowledge acquired by the ancient. For this reason, I will use the ancient medical traditions, such as traditional Chinese medicine that exists for more than 5,000 years, to explain which are the energy alterations before that is not causing the alterations in the laboratory exams. This is a tree metaphor that I usually use in all my presentation and in all my articles to explain the different levels of diagnosis and treatment between Western and traditional Chinese medicine. This tree is symbolizing the human being. This tree, you can see that separates by the earth, the parts below the earth and under the earth. The part below the earth, you can see that this tree has a trunk with several branches. Each branch represents one medical specialty, and coming out of each branch, you can see many leaves. In the case of fibromyalgia, it is usually treated by general practice or orthopedic or rheumatologist specialty, and it is treated in the leaf level, the pain in the leaf level. But according to traditional Chinese medicine, all symptoms and disease in all kinds of specialties, such as emotional or physical symptoms, the problem is not on the leaf. The problem is on the root of this tree that Western medicine usually do not treat or do not do the diagnosis, because it's Western medicine considered only scientific what they can prove by laboratory or radiological level, mainly after Flexner report after 1910. And also TCM considered the influence of these external pathogenic factors that could be influencing the generation of symptom and disease in this tree. In the root of this tree, you can see there are two theories in traditional Chinese medicine, that is yin and yang theory and the 5-element theory. The first theory is this yin and yang. Yin and yang are two energies that exist in our universe. They are opposite, but they are complementary, such as day and night, woman and man, sun and moon, and cold and hot, and there are other, for example, and these are the energy alterations that exist, that can have inside the body. The aim of all treatment is to balance this yin and yang energy to achieve health. And when the patient has some energy imbalances between these two energies, such as when the yin is lesser than yang or yang is lesser than yin, there are the development of some symptoms. In this case, when there is yin deficiency in relation to yang, there is a formation of some disease in the leaf levels, such as the formation of diabetes, women in menopause. All autoimmune disease are in this category of disease. And when there is yang deficiency, the patient could have cold hand and cold feet. They usually have liquid retention, obesity. They can have a tendency of having urinary incontinence, uterine prolapse, or prolapse of a rectum, or pregnancy, recurrent pregnancy losses, etc. For you, only to you to understand. And all treatments in TCM aims to balance these energies using some tools that I will explain to you. And yin and yang to flow inside the body, there is the necessity of have blood and qi in adequate amounts. And when there is yin and yang or qi or blood deficiency, there is a formation of internal fire inside the body. This fire is responsible for the manifestation of symptoms in the leaf level, such as infections and non-infectious disease. All infectious process has this energy deficiency and formation of internal fire. And there are many other publications that I wrote explaining how we can treat community and hospital infection without using antibiotics, only rebalancing this internal energy and and taking out these hits because this heat formation is responsible for the clinical manifestation of the infectious disease in the leaf level, community and hospital infection. And that's why there are some publications of mine showing the many kinds of infectious disease nowadays. We can treat only rebalancing this energy and taking out this heat. And there are other publications showing that some disease such as diabetes, for example, we need to treat this deficiency and taking out this heat to improve the hyperglycemia condition, because in the leaf level of this tree, usually Western medicine is usually using medication to reduce hyperglycemia, but the real cause of the formation of the disease is in the root of this tree, that we need to rebalance this water element that is where is the deficiency in diabetes that is causing the hyperglycemia condition. And for example, in all cancer patients, they all have this energy deficiency and formation of internal fire. And many other publications that I am writing, I'm saying that all patients with cancer also have these energy deficiencies and formation of this internal fire. And the treatment rebalancing this internal energy and taking out this heat, we can improve or we can cure. I have patients that only rebalancing this internal energy and taking out this heat, it was possible to cure cancer patients without using any chemotherapy or radiotherapy or even surgery. And these cases are all published online. To understand the progression from health to disease, there is divided in 5 phases. The first 3 phases is represented by only energy alterations, when the patient is having symptoms, but the laboratory exams are still normal. And fibromyalgia patients are in this category when they are having symptoms, many symptoms, but when the physician is asking for laboratory exams, they cannot find any alterations because the alterations are in the energy level. They cannot appear in the leaf level. The alterations in the leaf level in the laboratory exams can take for about more than 5 or 10 years of energy alterations to have alterations of laboratory exams in the leaf level. And the Western medicine can only do the diagnosis only in the phase 4 and 5 of evolution from health to disease, because it's in this phase 4 when there are some energy laboratory alterations. And when the patient is having hyperglycemia, high cholesterol, high triglycerides, and this means that the patient is having energy alterations before the alterations for years before. And that is why we are normally, I usually treat the patients in this energy level before producing energy laboratory alterations. And in the phase 5, the last alteration when there is cancer formation. And there are some patients and in some articles I'm showing that Western medicine usually say that it is irreversible, the cellular lesion, when the patient are in this phase 4, but there are some studies that I published showing that it is possible to treat these alterations, only rebalancing this internal energy and taking out the heat, and taking these patients from phase 5 to phase 4, or to phase 5 to phase 3, curing these patients, only rebalancing these energy alterations. And in fibromyalgia, according to traditional Chinese medicine, is caused mainly by blood deficiency. And blood deficiency could have these, the cause of this blood deficiency could be in these energy alterations in the root, because the blood is produced by the earth element or the spleen, and the spleen is in the energy point of view is responsible for the absorption of nutrients and the formation in all these patients with fibromyalgia, there is alterations in these earth elements, but I will show you one case report that I will show that all the elements here are in the lowest level of energy, and all the internal massive organs that are producing this internal energy is not working properly, mainly these earth elements, that is the spleen. And the blood is stored in the liver according to TCM, and this spleen energy is responsible for the production of blood. And according to the second theory in traditional Chinese medicine is the 5 elements theory. The 5 elements corresponds to wood, fire, earth, metal, and water. And there is a correspondence of these 5 elements and the 5 internal massive organs in traditional Chinese medicine. And all the things that exist in our world, in our universe, is composed by these 5 elements, and including inside the human body. And inside the human body, there is a representation of these 5 elements, such as wood represents the liver, fire the heart, earth the spleen, metal the lung, and water the kidney. And one element is interconnected by the other by the energy flow. And these way of thinking is very different from the Western perspective, when they understand that one organ works independently and separately. And when one organ is ill, the Western medicine usually treats only the organ that's ill. But according to TCM, the problem in the organ could be caused by the energy alterations in another organ. For example, it's very common in Western medicine to treat patients with asthma condition, giving medication to improve the lung. But according to TCM, the asthma is caused by deficiency in the next element, that's the kidney. And in TCM, to improve the asthma condition, TCM do not treat the lung, but they treat the kidney, that is usually very low in energy, that is published in some articles. But nowadays, I will explain to you that in a research that I did in my clinic in Brazil, studying 1,000 patients during 5 years, I measured the energy of these 5 elements. And in this research, I concluded that 90% of all my patients that I'm attending nowadays do not have any energy inside these 5 massive organs. And this situation is caused by the influence of the electromagnetic radiation after the implementation of 5G or 4G and 5G technology, leading to less energy inside these organs. And this situation is leading to a state of immune deficiency of our body, including us nowadays. And this is not happening only in my clinic, it is not happening only in Brazil, but it could be happening in the whole world, in the whole countries of this globe, because the influence of this electromagnetic radiation is affecting the whole globe, including the babies that are born nowadays, children, adolescents, young adults, and older patients. They are all in the same energy deficiency situation. And one of these disease that can be caused by this energy deficiency is this fibromyalgia condition. And here is the research that I'm showing that I studied during 5 years, studying 1,000 patient chakras energy centers. This is the result of this study. The first chakra corresponds to the liver, the second to the kidney, the third to the heart, the fourth to the lung, and 50 to the spleen. And 60 is this memory and concentration. You can see that the majority of us do not have memory and concentration, including children, babies, adolescents, young adults, and older patients. And the spiritual chakra only have energy in 80% of my patients, but 20% do not have energy. And this data was published in this article entitled, "Are we vaccinating immunocompromised or immunocompetent patients for COVID-19? In this article, I'm showing that the majority of patients that are receiving vaccines for COVID-19 are immune depressed medication, immune depressed patients because of this energy deficiency condition. And I measured the chakras energy centers studied by Ayurvedic medicine, because there are some studies in the literature correlating the chakras with the 5 elements in the 5 element theory in TCM. And when I measure the chakras energy centers, I can measure the energy of the 5 internal massive organs. All this reasoning began in 2006, that I treated one specific patient that I will briefly tell you his history. He was a 70-year-old male patient that came to my clinic due to leg pain, and he was using anti-inflammatory medication with no improvement of his pain during 6 months. And he went to my clinic to search for another kind of treatment. And his diagnosis in the root of that tree is a deficiency in the kidney energy in the water element. And to rebalance this energy deficiency, I use Chinese dietary counseling, changing some foods that he was ingesting, systemic auricular acupuncture with apex circulating, and he performed 10 acupuncture sessions and returned after 30 days. And he said that his leg pain improved very much, but he also improved from another condition that I was not aware, that he was treating for glaucoma for the last 40 years with no improvement of his condition. And after this treatment for his pain in the leg, his intraocular pressure reduced from 40 to 17. And that is why I told you that the treatment in the root of this tree can treat all the patient's symptoms, because he was having pain in the legs in the orthopedic specialty, but treating the root of this tree, he was having deficiency in this water element. Treating this energy disharmony in this root, it was possible to treat all the patient's condition. Here in the glaucoma, in the ophthalmology specialty, it was possible to regulate and to decrease his intraocular pressure that was not reducing, only using eye drops. And this theory was presented in 2015 at the Harvard Medical School in the Acupuncture Research Conference, when one of the titles of my presentation was Acupuncture Viewed Holistically Can Treat patients, all the patient's condition at the same time. Even the doctor does not know that the patient has such a symptom. And in this presentation, I will show you one case report of a patient that was treating fibromyalgia with the use of anti-inflammatory, antidepressant medication for many years without improvement of her condition. And he went to my clinic, and her Chinese diagnosis was blood deficiency, young deficiency, and heat retention. To do this diagnosis, I usually ask my patient if they have daily bowel movement. If they do not have daily bowel movement, this could mean blood deficiency. Young deficiency is when the patient feels cold in their feet, and heat retention is when the patient has dry mouth or bad breath or bleeding gums or abdominal pain or microhematuria, etc., or redness in the skin, itchiness, etc. And I measured her chakras energy centers, and showed that all her internal mass organs were in the lowest level of energy, meaning that the liver, kidney, heart, lung, and spleen was not working to produce the yin and yang qi blood. Yin and yang is produced by the kidney or the second chakra. The blood is produced by the spleen or fifth chakra. The third chakra, that's the heart, is for controlling the blood flow inside the blood vessels. And the distribution of this energy, all these energies is made by the liver and the lung energy, and all this energy is very low in this patient with fibromyalgia, and that is why in her treatment I used in the first step the alterations in her diet to avoid this kind of foods, because the ingestion of dairy products, raw food, cold water, and sweets can imbalance the spleen and pancreas energy meridian responsible for the absorption of nutrients. And the main orientation is to drink only lukewarm water. The temperature of the water should be at 32 degrees or more, because it is the temperature of the body inside the body. And when the patient ingests this kind of cold water, it could reduce the absorption of nutrients, inducing less formation of blood that is responsible for the fibromyalgia symptom. And the second group of foods that I oriented to avoid was the ingestion of, to avoid the ingestion of fried food, chocolate, coconut, honey, eggs, alcoholic beverages, melted cheese, because all these foods can increase the formation of internal fire that is one of the energy imbalances that it's causing the fibromyalgia symptoms, and avoid the ingestion of coffee, soda, matcha tea, because all these drinks could reduce the kidney energy that's responsible for the production of yin and yang energy. And that's why in the first step of the second step in her treatment was to do the apex bloodletting, auricular acupuncture, and systemic acupuncture. The apex bloodletting aimed to all kinds of pain. I needed to take out these to do the apex bloodletting. But there is one study that I presented in many conferences of acupuncture, showing that if you do not do this procedure, because if you take out 1 or 2 drops of blood, you can reduce even more the energy of the blood and can increase the fibromyalgia condition. And in some patients, I usually do not do this step, doing the apex bloodletting, only doing the auricular acupuncture with the mustard seeds. The intention to use auricular acupuncture is to balance these internal 5 massive organs. It is the kidney, liver, spleen, heart, and lungs. These are the 5 elements that I usually tone these organs using mustard seeds in the small adhesive tapes, and usually use systemic acupuncture with intention to balance the yin and yang qi and blood. This is the research that I did in my clinic, showing that all my patients were in the lowest level of energy. And the third step in the treatment is the use of high diluted medication to replenish these energies that is very low, to improve the production of this internal energy, to reduce the fibromyalgia symptoms. Why I'm using homeopathy medication? Because of the Arne-Schultz law, that is this law created in 1888 by 2 German researchers. And in this research, they are saying that the use of any high concentrated medication can reduce even more this vital energy. That is why the use of highly diluted medication, in this case homeopathy medication, is the medication of choice in the treatment of her condition, because this patient needs to have more vital energy. And the use of any kind of high concentrated medication will reduce this vital energy and harm even more her energy that is already low, that I showed to you. And not only this patient, but I am saying that the majority of patients nowadays are in this lowest level of energy. And then for this reason, the use of homeopathy medication, homeopathy is the medication of choice in the treatment of all kinds of disease nowadays, due to this less energy in this population nowadays. And this homeopathy is according to Hahnemann. Hahnemann was German physician that created homeopathy, and homeopathy has more than 243 years of existence. But the homeopathy nowadays the physician do not know the mechanism of action of homeopathy. And when I began my homeopathy course in Brazil in 2015, I began to write another theory in homeopathy, linking homeopathy with traditional Chinese medicine. And nowadays I can treat all my patients using homeopathy medication, but using traditional Chinese medicine to tone these 5 internal massive organs that are very weak in energy. Normally in China, they usually use Chinese herbs to treat this kind of energy deficiency in the 5 internal massive organs. But Chinese herbs is also considered highly concentrated medication and is not fitting to this new type of population that we are having nowadays. So when I needed to use Chinese herbs, I usually dilute them in the homeopathy pharmacy to give to this patient. And nowadays I'm using 5 homeopathy medication to treat all my patients because all of them has these energy deficiencies leading to a less immune system. And that's why to improve the immune system of our patients, we needed to use 5 homeopathy medication once a month for the entire life to improve the immune system. To treat the liver, I use phosphorus. To treat kidney, I use natrium muriaticum. To treat heart, I use sulfur. To treat lung, silica. To treat spleen, calcárea carbonica. This theory is on the internet. Is very important to us to use in all of our patients in all kinds of disease, because all of them are in this energy deficiency condition, including us nowadays. We could be in this energy deficiency and we need to use this kind of medication. That's the medication of choice in the treatment of all kinds of disease. And the aim of our treatment is to replenish this energy of the 5 internal massive organs to improve the production of internal energy, and in this case to improve the fibromyalgia symptoms, because the spleen that is responsible for the production of blood will produce blood in the adequately amount to reduce or to cure patients with fibromyalgia. And this is another article that I published recently in 2019, showing the cause in the energy alterations in fibromyalgia symptoms. And in this article, I'm showing that I studied 900 records. And from these patients, I selected 13 patients with fibromyalgia symptoms that corresponds to 37%. And I did a questionnaire by telephone call, and they give a numerical score to give for their pain, and 100% of the patients were female patients. I think these female patients is because of the menstrual periods that the female patients are having, that is they are have menses every month, and the deficiency of blood could be caused by this period of women. And the age groups that was very more common is after 45 age and 55, and they usually have pain in this site and in the whole body, or only in the legs, or in the cervical, or in this And here in this article, I'm showing that there are some energy alterations that we have in patients with fibromyalgia, such as blood deficiency or young deficiency, blood yin or yang deficiency, blood yin yang or qi deficiency. There is a combination of these energy deficiencies leading to the same condition of pain in the leaf level of this tree. And the localization of the pain is the majority in the cervical region, but could be in the, some are having this right cervical position, in the left cervical, and both sides. And here is the most age group are in the between 36 to 45 age of pain. And here is to show you that if the patient is using their products, they could reduce their pain only taking out all dairy products from their foods, because dairy can increase the pain in all kinds of pain conditions, and can reduce the absorption of nutrients and can reduce the production of blood. For this reason, it's very important to take out all dairy products. And here's to show you that the use of apex irregularity was not so good, because in this research, I'm showing that patients that do not do the apex irregularity have more improvement compared to patients that did the apex irregularity. Here are some articles that I'm saying that the population that we are treating nowadays are not the same as the population in the past due to these energy alterations. Before 2015, the population had normally had the energy inside the 5 internal masses of organs, but after 2015, suddenly the energy of quite the majority of population were the same, that is characterized by energy deficiency in all the 5 massive organs responsible for the production of internal energy. And this research I published in this article, Energy Alteration and Chakras Energy Deficiency and the Propensity to COVID-19 Infection, because the energy that is protecting our body is very weak nowadays, and that's why we are having this problem of this pandemic. And for this reason, I'm showing that we needed to treat this energy deficiency and not only giving the vaccines in our population, because the population is still very immune compromised, and we are not treating the cause and only the symptoms. Here are some articles that I'm showing that all patients that are having thrombosis, pulmonary artery thrombosis after COVID-19 treatment, and hospital infection nowadays are all caused by these energy deficiencies in the 5 internal massive organs. That is the same cause of the fibromyalgia symptoms nowadays. And here are some articles showing that the homeopathy is the medication of choice in prevention and treatment of COVID-19 infection due to these energy alterations that our population is having nowadays. And only these are all articles showing the treatment of our patients we needed to use high diluted medication nowadays due to this energy deficiency pattern. And for this reason, the patients that are having fibromyalgia are not responding to anti-inflammatory medication or antidepressant medication, because we are not treating the cause. And the use of any kind of high concentrated medication can reduce even more this vital energy that's already low, worsening the symptoms in the leaf level. And only to show you that homeopathy and acupuncture in Brazil are considered medical specialty by the Federal Medical Council, and they are very important tools nowadays to treat all kinds of disease in all kinds of specialties because of this new energy pattern of our population that is already low, and we needed to reduce the use of any high concentrated medication to do no harm to this vital energy that is already very low in all kinds of disease nowadays. And the conclusion of this study is that patients with fibromyalgia have energy deficiencies in the 5 internal massive organs. And the tools used in Chinese dietary counseling, auricular acupuncture, and replenishing these 5 massive organs energy using high diluted medication, or using this theory that they wrote constitutional homeopathy of the 5 elements based on traditional Chinese medicine, is very important to treat the cause of the pain manifestation and not just the symptom presented by the patients. According to Hippocrates, it's far more important to know what person has a disease than to know what disease this person has. In this quote, he is saying that we need to treat the patient and not the disease. If we treat the root, that is the patient's energy imbalances, we can treat all the patient's condition at the same time. But if we only still treating the symptom at the leaf level, we can harm the vital energy that's on the root of this patient and aggravating the patient's condition. Thank you for your attention. Sorry for the long presentation. This is my email address. If you want to connect with me or ask some question, I will be very happy to answer you. Thank you.
Thank you, Dr. Wang Ling, for your presentation. So, anyone have any questions? Okay, no questions. Thank you once again for your presence and presentation.
You're welcome.
Yes. So our next presenter is Dr. Priyanka from Pandit Bhagwat Dayal Sharma University of Rohtak, India. Hello, Dr. Priyanka. Hello. Am I audible, Dr. Priyanka? Hello, Dr. Priyanka. Am I audible to you? Okay, I think she is not active in the webinar. So we'll go with the another presentation from Dr. Kimberly Hines Henson from University of Nebraska Medical Center, USA. Hello, Dr. Kimberly. Can you able to give the presentation now?
Good morning. How's everyone doing? Of course, it's probably not
Yes.
morning where you are. I
No,
need
for us it's afternoon. Yes. So you are the presenter now.
Okay, I
Please
got to
share
figure out
your
how to
screen.
share my slides here. Okay. All right. Can
Yes,
you
we
see
can
my
able to
slides?
see that. Yes, yes. You can make it a
Okay.
full screen.
Yes.
Yep. Yes, perfect. Please
Okay.
continue.
Well, thank you for all joining us today. I'm very happy to be here. It's a privilege to present about important topics such as this. So we're going to talk about nonsteroidal anti-inflammatory medications for both acute and chronic pain. Hang on, I gotta figure out how to forward slides now. Oh, here we go. All right, so I'm presenting to you from Omaha, Nebraska today, which for those of you who don't know is pretty much the dead geographic center of the United States. In fact, when I had to move here, I looked it up on a map because I didn't know exactly where it was. And I couldn't find the city because it was in the fold of the map. You can tell it was a while ago because pretty much everybody just looks it up online now. Our objectives today is to discuss the importance of nonsteroidals and a brief bit about the pharmacology, and talk about how patients are likely to do if we prescribe these medications for patients. And then we'll talk about a few different characteristics of some of the medications and how they can be best utilized. Why should we bother with non-opioid treatments such as nonsteroidals? It would be so easy just to grab your nearest morphine pill or codeine or whatever and prescribe it for patients. As you may or may not know, in the United States, overdose deaths have been rising rapidly. And we reached a new record in the last 12 months, ending April of 21, where we had over 100,000 deaths from overdose. And of those 100,000, about 75,000 of them were from opioids. So you can see we have a major problem here. Law enforcement has been seizing fentanyl at 50 times higher rate than in the last 4 years. So this problem's not going away or not decreasing. If anything, it's gaining ground. Most people who become addicted to opioids or have opioid use disorder originally get their medications from their physician or provider, and then they move on to their family members or friends. So as providers, if we can decrease the number of pills floating around in the community, then we should be able to have somewhat of an impact on this, although I kind of feel sometimes that we've let the cat out of the bag, to use a metaphor. Opioid use disorder can either begin quickly, but for most people, it is a gradual process, starting with physical dependency, which then, of course, encourages continued use, and then tolerance builds. And so patients start escalating their drug levels because they feel like they need more medication to get the same amount of treatment. So we have a lot of non-opioid therapies, nonsteroidals being one of them. And then, of course, we can also use non-medication treatments and non-opioid treatments as well. So nonsteroidal anti-inflammatory medications have been around for literally thousands of years. Hippocrates began noticing that the extracts of poplar and willow bark could be used for reducing reducing pain and eye diseases. And this was back in the 5th century BC. This is quite a long time ago. And then in the 18th century, Stone isolated salicylic acid from myrtle, which is the tree that you see on the screen here today, and willow back in the 18th century. And then, of course, Hoffman created acetylsalicylic acid for Bayer, which then, of course, became aspirin over time. So you can see this, we have a long history of utilizing these medications, not without risk 100%, of course, but they've been a very mainstay of pharmacotherapy for a long time. The World Health Organization put together guidelines for treatment of cancer pain, and these guidelines have been extrapolated out to treat patients without cancer pain as well. And block number 1 at the base is the non-opioids plus or minus adjuvants. So in here would be where your nonsteroidals would be first applied to treat pain. And then moving on to the second layer, when the WHO put this together, their drug that they were using for the example of 2 would be a codeine type opioid. And then 3 would be morphine or something to that effect. At that same time, they also developed some treatment guidelines, so they were doing a very good job with completeness. We use the nonsteroidals primarily for the 3 actions that they are most likely to give us, which is analgesia, antipyretic, for fevers, and then the anti-inflammatory for those with osteoarthritis or even rheumatoid arthritis. And of course, these medications work because they inhibit prostaglandins from forming from arachidonic acid, and they acetylate both COX-1 and COX-2 receptors. So let's take a quick look at what this actions can do for us. Of course, the common adverse side effects are the increased risk of thrombosis leading to myocardial infarction from the cardiovascular effects. Hematological, which sometimes we utilize on purpose to treat those with heart disease, is decreased platelets, but also with the decreased platelets is the risk of bleeding. And then, of course, with the renal impairment, sodium and water are retained, and this can lead to renal failure. And the gastrointestinal effects can cause ulceration and then bleeding from the platelet dysfunction that is present. And this is a quick look at the inflammatory cascade. Up here at the top, we have the phospholipid bilayer of the cell, which becomes damaged, which then releases this phospholipase A2. And then that converts to arachidonic acid and then to prostaglandin. And right underneath prostaglandin, you can see COX-1 and COX-2 as the enzyme that converts into the primary products of thromboxane, prostacyclin, and prostaglandin. And then, of course, the nonsteroidals will inhibit both COX-1 and COX-2. And that leads to a decreasing effect of these thromboxane, prostacyclin, prostaglandin on the human body. There's a spectrum of both COX-1 and COX-2. So here's a list of commonly used nonsteroidals, certainly not a complete list. But mostly COX-1 would be ketorolac, indomethacin, aspirin, naproxen, ibuprofen. And then there's a fairly short list of those that are more or less 50-50 COX-1 and COX-2 mechanisms, which is phenoprofen, sodium salicylate, piroxicam, diclofenac, celecoxib. And then mostly COX-2 would be meloxicam, etodolac, and then valdecoxib and rofecoxib, which are off the market right now in our country at least. So acute pain, these medications can be very effective. We've studied this a lot in the operating room because that's a very controlled environment for both studying acute and somewhat chronic pain. We know that these medications are opioid sparing in the postoperative period and in the first 24 hours, which causes a decrease of both post-op nausea and vomiting and morphine use or stronger opioid use. And even in the postoperative period, we've had studies that indicate that 81 milligram dose does not have any significant bleeding risk, which allows it to be used in cardiovascular patients, which can help decrease their postoperative risk of cardiac events. And then in healthy patients, we do know there's a very slight change in creatinine clearance with the acute use of these medications, but it's not significant. So even though that we know that the COX-1 especially can have some significant thrombotic events, it doesn't appear to be showing that in the postoperative period. We know that these medications can operate both peripherally and centrally. For a long time, we thought only periphery was affected by nonsteroidal anti-inflammatory medications, but we have since found that both COX-1 and COX-2 act in the dorsal horn of the spinal cord. And in the periphery, the prostaglandins sensitize these nerve endings to respond to non-painful stimuli with a painful response. So that's why in the acute pain setting, these medications can be very effective in decreasing postoperative discomfort. All of these medications, in chronic pain, we find that it's more effective to use medications with a shorter half-life to decrease the risk of long-term events. We know these medications are rapidly absorbed after given orally. They're highly protein bound, and that helps them accumulate in inflamed tissue. Also, most of these medications are a prodrug that can be converted into an acidic-based drug. So the fact that it's acidic allows it to be attracted to inflammatory sites because those are also acidic. So it has better penetration there. These medications also accumulate in the GI tract, which does lead to their side effects. It is also concentrated in the kidneys because it is excreted in the kidneys, although it is all of them are all of them are metabolized in the liver with the P450 system. So many of these medications long-term do have cardiovascular risks, but naproxen seems to have a pretty benign level of risk. So it's similar to aspirin and doesn't seem to have some of the other properties of, say, ibuprofen. And we know that COX-2 inhibitors do decrease the GI risk, but they do tend to increase the cardiovascular risk and the risk of thrombosis. Long-term use can also increase the risk of hypertension, and both either the selective selective COX-2 or the non-selective should not be used in patients with severe cardiovascular risk. The FDA consensus statement on cardiovascular risk with celecoxib versus the non-selective is similar, but they do admit that more studies are needed on the cardiovascular effects. And of course, the renal effects are increased in those who have pre-existing disease and magnified by dehydration. So drug characteristics, we do use aspirin because of its irreversible effect on platelets, and this does allow to decrease thrombotic risk in patients who have cardiovascular disease. In low doses, it causes platelet inhibition. At medium doses of aspirin or acetylsalicylic acid, it has some antipyretic and analgesic effects. And in high doses, it has anti-inflammatory effects. The acidic nonsteroidals, which are part of the propionic acid class, like diclofenac, ibuprofen, and ketoprofen, have significantly more protein binding than some of the other nonsteroidals and tend to accumulate in inflamed sites more easily, especially diclofenac, which will accumulate in synovial fluid, so it can be very helpful for joint arthritis. Ibuprofen does have a black box warning here from the FDA for cardiovascular and myocardial infarction, whereas naproxen does not. Nabumetone is one of the nonsteroidals that does seem to have somewhat of a GI protective prodrug involved with it. So patients are at high risk of cardiovascular use, probably you wouldn't want to use it at all. But in those who are maybe at more moderate risk or mild risk, this might be a good medication choice. And then meloxicam can be a COX-2 inhibitor at the low dose, the 7.5 milligram dose, but at the 15 milligram dose, it tends to be more non-selective. In special populations, for those in renal failure or with renal disease, there's pretty much no safe nonsteroidal use. So those should just pretty much be avoided altogether. Those with renal disease are 3 to 4 times more likely to have increasing problems with excretion, and this risk is compounded with other nephrotoxic drugs like aminoglycosides, contrast, diuretics. Nonsteroidals should also be avoided in those who have a single kidney, either because of surgery or because they were born that way. Patients with liver disease should avoid nonsteroidals if they have severe disease, but mild to moderate disease can usually use nonsteroidals safely. The exception to that is diclofenac, which is probably not something that should be used with anyone with liver disease at all, along with aspirin and acetaminophen or paracetamol. And of course, the elderly have higher risk of cardiovascular disease and GI effects, but these medications can be opioid sparing, which helps avoid oversedation, delirium, and respiratory depression. The lowest effective dose should be used for all of these medications, especially in the elderly with their decreased volume of distribution. So just to make sure everyone's still awake, I have a question for you. 75-year-old male presents to clinic with knee pain. He had myocardial infarction 2 years ago, but BUN and creatinine are normal. What nonsteroidals would you consider? So I kind of feel like an MI 2 years ago, this guy's pretty high cardiovascular risk still. So I would not be super excited about meloxicam at the 7.5 milligram dose because that's a COX-2 selective that will increase the risk of myocardial events and thrombotic events. Naproxen, possibly a good choice. It has less cardiovascular events associated with it. Ketorolac is a very strong COX-1, so probably not the best for him just because of the other side effects on renal disease, GI, etc. for a 75-year-old. So I think the best answer is acetaminophen or paracetamol. You could argue with me, and you could probably be right too. Another option might be diclofenac gel. Applied topically, this would have fewer risks for this patient. So I know this has been a relatively short talk, but hopefully you've learned a few extra things to help with your patient care. In summary, nonsteroidals, healthy patients can use with minimal to no side effects. Acute pain in that setting, it can be very opioid sparing, decrease post-op nausea, vomiting. With the opioid sparing, of course, that can help it decrease the risk of delirium and oversedation and respiratory depression. Chronic pain, side effects, of course, should be monitored carefully by the provider. Nonsteroidals are excellent drugs that are relatively well researched because since they've been around so long. But while we're waiting for the perfect drug with no side effects, this class can be utilized for its known benefits of pain relief and fever relief and help decrease inflammation as well. And these are my references if anyone's really bored. Does anyone have any questions? I would love to say it looks like this in Nebraska all the time, but we do have blizzards and tornadoes too, so.
Thank you, Dr. Kimberly, for your presentation. So anyone have any questions?
Well, thank you very much for listening.
Okay, no questions. Thank you once again for your presence and presentation. Yes. So our next presenter is Dr. Priyanka, and the title of the
Hello, ma'am.
talk is used to describe chronic musculoskeletal pain in Hindi language. Hello, Dr. Priyanka. I'm going to make you the presenter. Yes.
Hello, ma'am. Is my voice audible?
Yes, your voice is audible and we can able to see your screen as well. Yeah, you can make it a full screen.
Okay. Um, from where I can move this icon in front of my slide.
Yes, you can continue with your start presentation.
Okay. Good afternoon, one and all present in today's conference. First of all, I want to thank and congratulate the organization team of today's conference. My name is Priyanka and I basically belongs from India. I currently pursuing my post-graduation from North India's one of the prestigious institute, Pandit Bidhi Sharma University of Health Sciences, under the guidance of Dr. Bhavna Verma, who is an associate professor at College of Physiotherapy of the same university. And my topic of today's talk is word that used to describe chronic musculoskeletal pain in Hindi language. Pain is a multidimensional experience and subjective in nature. Most of the aspect of the pain assessment relies on description of one's experience. Pain assessment include pain intensity, type, location, duration, and aggravating and relieving factors. Words used to describe pain have an important role as a self-report gold standard method for the assessment. Most of the time, the pain is considered as a single item measure of pain intensity using via VAS and NPRS scale. The description of pain experience can help in differentiating various chronic pain conditions, including pain sensation, mechanism of pain, and effectiveness of treatment. There are various measures that are being originally used, including McGill Pain Questionnaire and its revised version, Pain Quality Assessment Scale and its revised version. What is the need of the study is Though there are various scales that are originally well developed and validated in English speaking population, but in North India, according to census 2011, India Hindi language is the most prevalently spoken language. It is approximate 425 millions that people that used to speak Hindi language, but till date no studies are available that describe common word used by Hindi speaking population to describe their pain. So our study is basically provided that the commonly used word by the patient in Hindi language to cover the gap of communication between the medical specialist dealing with the pain management and the patients. Talking about review of literature, work on initially the pain quality descriptors is done by Maljack in 1975, who developed a gold standard tool known as McGill Pain Questionnaire with 78 descriptors. Later on in 2006, Jensen developed pain quality assessment scale by working on patients with carpal tunnel syndrome and developed the scale with the help of 20 measures. In 2011, Lin et al. And in 2013, Jensen, and in 2016, Thakral had conducted a similar kind of studies to find out what are the common descriptors for different kind of conditions and check the validity of existing measures, and found that only in different kind of population and different kind of cultures, different scales are found validated. In 2016, Sharma conducted a study in the Nepalese population to find out the common words that are people use for describing their pain, and found it that there is some difference in the word that people provide, Nepalese population provide, different from the USA population, and concluded that there is a strong role of culture in the language on the validity of any measure. And in the 2018, Rao et al. Conducted a study and evaluated the most commonly pain descriptors for shoulder pain, and found that sore and the pull were the most common words, and female provide more descriptors in comparison to the male patients. Aims and objectives of the study is to find out the common Hindi pain descriptors and to find out the impact of the relation of the gender with respect to the description abilities of the individual. An objective of the study is to identify the common pain descriptors by the medical specialists who are dealing with the musculoskeletal pain, and to classify and code the different pain descriptors into various domains and subdomains. Flow chart of the study is the study was started with the help of an interview schedule in which the physiotherapist and orthopedicians are consulted to fill the self-developed interview schedule regarding the Hindi pain common descriptors, and the responses of the individuals were categorized into Excel sheet and then again classified into various domains and subdomains. Later on, statistical calculations of the data or rates or frequencies of the descriptors were calculated. Methodology of the studies. Study design is an exploratory research designed to explore what are the different new words that Hindi population use for describing their pain. And the study setting is at Pandit B.D. Sharma University of Health Sciences in India, with the sample size of 50, by selecting with the sampling technique convenient sampling, because according to Wislow, no more than 50 interviews are required for a qualitative and analytical research. The inclusion criteria for our study was medical specialists, including physiotherapists and orthopedicians, those who are working in Rohtak district and have the experience of 2 or more years after their post graduation, were included in the study, and the individuals who do not fill the same criteria were excluded from the study. Process of the study is initially the medical specialists are consulted to fulfill the self-designed questionnaire, and to find out the or to obtain the common descriptors, they are first asked to provide the common 10 descriptors in Hindi language, and later on they were asked to rate the translated version of the McGill pain questionnaire and pain quality assessment scale. In the data analysis, first the descriptive statistics of the data was calculated. Later on, the frequency and the rates of different descriptors were calculated. And in particular, because we are interested in finding out the impact of the gender on the description abilities of the individual, we have checked the gender impact and found it that the female provide more descriptors in comparison to the male individuals. If we talk about the result, in the table number 1, we can see that more of the patients were in the 25 to 30 years of the age group. 68% of the population of the respondent belongs to the early adult age group. In the table number 2, it signifies the gender based description and signifies that 62% of the population of the respondent were female. In the table number 3, it's a qualification based description, which indicates that 74% of the individuals have experience post their masters of physiotherapy. And in the next table, we can see that the year of experience that the respondent is having, because more of the individuals are in the younger age group, and the most of the individuals belong to the age criteria years of experience of 2 to 6 years. Talking about the preference of the pain intensity scale, 58% of the individual or the respondent preferred VAS scale, and 42% of the individual preferred numeric pain rating scale over the 100 PESA scale or the facial PESA scale. In the next table, individuals have provided the preference for the pain quality scale. It is surprising to know that 50% of the respondents did not prefer any pain quality tool for Hindi speaking population, whereas 26% of the individual prefer McGill pain questionnaire and 24% of the individual prefer pain quality assessment scale. In the next table, when we ask the individuals about the requirement of or need to develop Hindi tool, 92% of the respondent provided the yes answer for the need of Hindi pain descriptor measure. Talking about the gender impact, 70% of the respondent provided that the female provide more descriptors in comparison to the male patients. In the table number 9, we have classified different pain descriptors into various domains and the subdomains. There are majorly 6 major domains, including sensory quality, sensory, which is further classified into sensory quality and sensory metaphor. Sensory domain explains that what kind of pain the patient feels. And in the sensory metaphor, these are the common phrases which are not usually the word, but the kind of feel the patient feels and explain its own language. Next major domain is correlate domain, that is the cause of the pain, that what can be the relevant cause of the pain the patient explained, we have categorized in the correlate domain. And in the interference or the effect domain, we have concluded that what kind of effect on the pain on individual life is. In the temporal domain, we have concluded those descriptors that explain that how frequent or how much common the pain is to the individual. In the effect domain, we have concluded that how the pain is bothering or how unpleasant the pain is to the individual. And in the magnitude domain, we have concluded those words which indicates the intensity of the pain. So in the sensory quality, radiating, piercing, lacerating, or sickening or taut type of the pain were the most common words, including झंझनाहट, चुभने जैसा दर्द, and फटने जैसा दर्द, पीड़ादायक, or the taut was the most common descriptors. And talking about the sensory metaphor, चींटी चलने जैसा, like an ant moving, reel चलने जैसा, like a thread moving, नस खिंचना, like a nerve stretch were the most frequent sensory metaphors. In the correlate domain, stiffness or the accident is the most frequent word, and in the interference domain, tiring or the thakane wala type pain is the most common descriptor. In the temporal, constant or the lagatar is the most common descriptor provided by the medical specialist. In the affect domain, bhadak or lassitude is the most frequent, and in the magnitude, there is tej dard, that is intense, was the most frequent descriptor provided by the medical specialist. In the table number 10, we have concluded the words having a frequency of more than 10 and the metaphors or the phrases having a frequency of more than 5 as the final words that we have collected from the medical specialist. In the table number 11, we have signified that the word, we have asked the specialist that do the words or the descriptor indicates toward the pain mechanism, and 100% of the individual responded with the answer that the words of the pain or the patient provide a indication toward the mechanism of the pain. In the next table, you can see that there are different type of mechanism behind the pain, including nociceptive pain, nociplastic pain, and neuropathic pain. In the nociceptive pain, the pain is due to activation of nociceptors, including either due to inflammation, mechanical irritant, or the injury. In the conditions like osteoarthritis, ankle sprain, or rheumatoid arthritis. So in the conditions including, if we see the descriptors for nociceptive pain, shooting or throbbing type of pain, or the cheese word was the most frequent descriptor provided by the medical specialist. And if we talk about the neuropathic pain, the pain is due to the lesion or the disease of somatosensory system, either due to for example diabetic neuropathy, carpal tunnel syndrome, or complex regional pain syndrome. And the common descriptor was the jhanjhanahat, that or the tingling provided by the medical specialist. In the centralized or the nociplastic pain, the disturbance is either in the central processing, either due to increase in the excitability or decrease in the inhibition, like in the cases of fibromyalgia, temporomandibular disorders, in those specific low back aches. And the common word for describing such kind of mechanism were meetha meetha dard, that is aching pain, was the most frequent descriptor. And in the mixed kind of variety, where the all kind of nociceptive, neuropathy, or centralized kind of pathologies can be present at one time, heavy or bharipan is the most common descriptor provided by the medical specialist. In discussion, though good quality assessment scale like McGill pain questionnaire, pain quality assessment scales are available, but still direct translation of these measures developed in one country should not be assumed to be content valid in different cultures, different languages and countries. The guidelines for translation and adaptation strongly advocate the need of considering cultural aspects and the regional language aspects, and says that the language and culture has more important role in the validity of any measure at different countries and the languages. So meaning of the directly translated words or the phrases may not be applicable in a new context. As pain is a subjective experience, identification of these common words is a very ultramost important, or we can say that for the treatment purpose or identifying the mechanism of purpose can be very helpful. So our findings of the current study is providing a preliminary guidance regarding the development of a Hindi measure of pain quality. Of the various domains, pain quality was the maximum subdomain in the maximum subdomains present in the sensory quality and the sensory metaphor. And the commonly used sensory quality descriptors were meetha meetha dard, that is aching pain; cheese is the throbbing or shooting pain; janjanat is tingling or chubhan pricking; shunpan, that is numb; khichav is tugging or pulling; bharipan is a heavy kind of descriptors are provided by the medical specialist. These descriptors are similar to those reported by Jensen et al. In 2013. And the top 5 pain quality descriptors in the US population were sharp, achy, throbbing, cramping, and burning and dull. A similar study in the Nepalese population done by Sharma et al. Showed that the burning, tingling, piercing, heavy, numb as the most commonly sensory descriptors. It was also noted that the patient used commonly sensory states for describing their achiness and tingling in their pain. The Nepalese patients also used sensory metaphors similar to our study. Only very few descriptors for spatial, correlate, or temporal domains were used. Commonly used descriptors in the affect domain were bhadak, that is lassitude, and asahaniya, that is intolerable, was there. It was also seen that the patient generally used descriptor to describe the magnitude of the pain. And if we talk about the mechanism of the pain, or the words as a indicator toward the mechanism of pain, all the respondents believe that the pain descriptors provide an indication toward the mechanism of the disorders. All the words which indicate toward the pain were from sensory quality, except except the intolerable or asahaniya pain from the affect domain. This shows that a pain quality assessment tool in which the words are grouped into categories indicating toward a certain mechanism can become a very helpful tool for pain assessment. Various treatment strategies may be used for mechanism-based management of the pain. The concepts like explain pain, in which instructional design and multimedia principle to present pain biology information for treatment to alter the patient's thinking about the pain, was used. The availability of commonly used pain descriptors in native language will provide help in the treatment strategies. Limitation of our study is that the present study is a part one of the study to develop a Hindi pain quality assessment measure, and the next step we will gather the data directly from the patients and a comprehensive list of the pain descriptors would be finalized. Last but not the least is the conclusion of the study is the study present 15 more commonly used Hindi pain words and the phrases used by the patient, as we all can see in the word cloud, and the tingling is the most frequent word explained by the medical specialists. Thank you for your patience listening, and I welcome you all with your questions.
Thank you, Dr. Priyanka, for your presentation. So, any questions from anyone? So, no questions. Thank you once again for your presence and presentation.
You're welcome.
Okay. So, our last presentation is by Dr. Shweta Puvani from Raja Rajeshwari Dental College and Hospital in Bangalore, India. Hello, Dr. Shweta.
Hello, can you hear
Yes,
me?
yes. So,
Yeah,
you are the presenter now. Please share
yeah,
your screen with
thanks.
us.
Yeah. It's saying that you need to
Yeah, I
make
already
me the
gave you
present.
the, just a minute.
Yes.
Yes. Now you can try. Yeah, hello, Dr. Shweta. Is there any issue? Yes, we
Yeah,
can able to see your
yeah.
screen. Yes.
Screen, okay. Just a second.
Yes, we can able to see your screen. Also, you can make it a full
Yeah,
screen.
yeah.
Yes, so now it is okay. But
Fine.
Dr. Shweta, just a
Okay.
minute. We have a
Yeah.
question from Dr. Mattia. Just a minute. To Dr. Priyanka. Hello, Dr. Priyanka.
Yes.
Yeah, we have a question from Dr. Mate Sinos that did any language expert was in the study is included?
Yes, ma'am.
Okay. So Dr. Mate, she has answered your question. Do you have any further questions? Okay, no more questions. So Dr. Shweta, you can proceed with your further
Thank you.
presentation. Yes.
Yeah. Thank you. Very good afternoon, all. Thank you so much for considering me for the presentation in your second international online conference on pain research and management. Here am I presenting to you all from India. Myself, Dr. Shweta Puvani, Professor and Head, Department of Prosthodontics, Rajarajeshwari Dental College and Hospital, Bangalore, India. Yeah. The topic of my today's presentation is on management of pain in occlusomuscular disorder and evaluation of joint health. So, all of us are aware of the term orofacial pain, which comprises different manifestations of pain in the face and oral cavity. It is a broad classification including many conditions highly prevalent in general population, such as pulpal and periodontal process, sinusitis, trigeminal neuralgia, and masticatory muscle and temporomandibular joint pain. All of us have seen patients coming up with the tautness in the face, like patients having migraines, eye pain, jaw pain, neck and shoulder pain, uh, with dental pains, ear pain, or tinnitus. Now, the later two conditions fall under a group of conditions named temporomandibular disorders. Now, it is a collective term embracing a number of clinical problems that involve the masticatory muscles and/or the temporomandibular joints and associated structures. The most frequent symptom is pain, usually located in the masticatory muscle, preauricular area, and or temporomandibular joint. In addition to pain, which is usually aggravated by chewing and other jaw functions, patients with temporomandibular disorders often have limited asymmetric mandibular movements and joint sounds. Commonly, they are described as clicking, popping, grating, or crepitus. The temporomandibular disorder patient also describe symptoms of pain and dysfunction affecting ears, eyes, and or throat, as well as headaches, which involve some or all of the frontal, temporal, parietal, and occipital and neck regions. Some of the symptoms of TMD, as you can see here, the pain or tenderness in the jaw or the joint area and the face, pain in and around the ear, the headaches and the neck aches, the swelling on one side or sides of the face, the jaw getting stuck or locked in an open or closed position, the jaw pain while chewing, speaking, or opening the mouth wide, the popping or clicking noises when opening in the mouth, and difficulty opening the mouth all the way. So we have lot of these chronic occlusomuscular disorder is a myogeneous subset of temporomandibular disorders. So dentists have various treatment options over a period of time for these treating these temporomandibular disorders, such as hands-on manipulation to improve the jaw movement and relieve the joint pain, exercise stretches to the strengthen the muscle and improve function, posture education to correct positions that may be causing dysfunction, special treatments like dry needling or electrostimulation to promote healing. We also give cold packs or muscle relaxant, anti-inflammatory drugs, changing of the sleeping habit, elimination of stress, massage therapies, and all of us are aware of the splint therapies. And we have areas of medicines available to reduce the pain. Now, this is a Botox injections to the triggered area. So usually, the temporomandibular muscle pain cycle, if we see any traumatic or physiological, metabolic, or mechanical stimulant can cause the muscle pain and dysfunction. Now, what does this cause is constricted blood supply, accumulation of waste products, and less oxygen. Now, which leads to the chemical changes in the muscle, inflammatory chemical buildup due to muscle fatigue, which in turn cause the muscle soreness and spasm, due to which there is abnormal involuntary muscle contraction, which causes or sends pain signal to the brain and stop the muscle movement. So hence, coming to the temporomandibular disorder signs and symptoms, they are one of the highly complicated fields in dentistry, and it can emerge in various manners, as we can, this picture depicts. So the signs and symptoms could be in head pain in the headache, or pain in the ear, discomfort or limited mouth opening or something seen in the mouth, the teeth, that is causes clenching, grinding at night, soreness of the teeth, thermal sensitivity, and there could be generalized bare facets, and we can see the problems in the ears, jaw problems, neck problems, where we have lack of mobility, stiffness, neck pain, tired or sore muscles, shoulder aches, back aches, arm and finger numbness or pain, and even some symptoms are also seen in the throat. Now, in dentistry, there is no other problem that must managed in a multidisciplinary fashion like temporomandibular disorder. Occlusal trauma is that one thing what we highlight here in this presentation, which can cause temporomandibular disorder. So the role of occlusion in activating the myofascial pain dysfunction syndrome has long been debated by so many authors. So some studies by Robert Christian have shown that occlusal equilibration to be a, to be a successful treatment modality in treatment of such disorders. So many studies indicate that ICAGD treatment will likely reduce the myofascial pain dysfunction syndrome due to the physiologic muscle activity lowering effect achieved by doing this DTR therapy. Then, when the attempts were made to retrude the mandible or traditional occlusal equilibration procedure. So these are the various kinds where we see the occlusal muscular problems, where the patients are finding difficulty in all these symptoms. Usually what happens is when the teeth are coming in contact, there is lengthy disclusion time has been seen, that is the elevate the muscle activity level, which is shown in a EMG study, and a proper reduction in the disclusion time, that is when you close and open the mouth, that is the disclusion time, which should be less than 4 seconds, can reduce the muscle hyperactivity and the related symptoms. Now, the beauty of this computer guided treatment, what we are going to discuss, is that it lessens the hyperactivity of the muscles within the central nervous system by controlling the molar periodontal ligament mechanoreceptors, which synapse directly with efferent motor fibers that contract the four masticatory muscles, basically the masseter and the temporalis. Prolonged excursive frictional contacts increase the total time. The PDL mechanoreceptors are compressed in the excursive movements, where the PDL compression time is equal to the disclusion time of the same excursion. The more time the excursive interference contact, the longer time the PDLs are compressed, and resulting in the prolonged duration of the masticatory muscle contraction. Now, by reducing the length of the time, the posterior occlusal surface contact excursively, the volume and duration that the pedial mechanoreceptors are reduced, thereby interrupting the pedial compression to muscle hypercontraction. Post ICAGD, that is, before doing the treatment, the patient will be expressing all these pains in the muscles, bone, and the joint. So, post ICAGD, the PDL no longer hyperfunctions and the involved muscle uh, into a ischemic state, allowing it for reoxygenation and muscle fiber recovery, leading the some symptoms resolution without the patient wearing any kind of appliances what we had seen earlier. Okay, and undergoing a transcutaneous electric nerve stimulation or taking any painkillers or muscle relaxants or anti-inflammatory drugs. So properly performed ICAGD has shown marked improvement in the treatment of myofascial pain dysfunction syndrome. So, a large number of devices and methods are used for the diagnosis and treatment of this kind of occlusomuscular temporomandibular disorder. So, we have different, as we know, the one of the most widely used diagnostic tool to detect the pathology is the MRI or the CBCT of the temporomandibular joint. And we have this newer biometric tools, which are the newer invention. Like from past 20 years, lot of research has been happening, but of late we are getting familiarized with these tools and lot of studies have been carried out. So the temporomandibular joint vibration analysis has been for the precise recording of the joint vibration in a computerized process of recording vibrations bilaterally from the joint and processing these vibrations in a software to arrive at a reliable indication of whether the joints are normal or damaged. So these are the basic imaging techniques what we use to do the evaluation of temporomandibular joint. Now coming to these biometric gadgets, this is a T-scan what I was talking to you about the performance of ICAGD or reducing the high points in the present in the teeth where we reduce the disclusion time to zero point 0.4 seconds. And this is a newer version of T-scan. As we can see, this is the bio-JVA. This is just like a headset where the earphones are just placed anterior to the joint cavity. So this is in turn connected to the biopack software along with the T-scan, and this is the EMG. Now you have different channels here for the masticatory muscle. It is a surface EMG where simultaneously when the patient is biting, so the EMG also will be activated, and all these gadgets help for the precise recording and analysis of temporomandibular joint, like range of motion or any lateral deflection or maximum opening or inputs of any JVA. Hence, the study was conducted to analyze the joint health before and after the disclusion time reduction therapy for people who are diagnosed with occlusomuscular conditions using the JVA and the Biopack software. Uh, So these are the different classifications of temporomandibular disorders. So here we just followed the Piper's classifications 2, 3A and 3B. We just limited ourselves to 3A and 3B because they are all basically the occlusomuscular origin. Here the question is, if the TMG problem, if it is under 3A and 3B, if it can be reversed, or if it is in the muscular level, if can it be reversed, then the answer is yes. So our study is basically done with the objective of precisely characterize the TMG vibrations of patients with occlusomuscular disorder of both the genders with JVA before and after the disclusion time therapy. And we compared the joint activity of these patients. Coming to the methodology, patients who visited our Department of Prosthodontics orofacial pain clinic section with the TMD were selected. The patient volunteered to participate in the study, and the patients were properly informed and provided consent. So a total 52 subjects were selected according to the Mark Piper's classifications, uh, who were identified with myofascial pain. These patients had to undergo the DTR therapy. Basically, the DTR therapy, where the using the T scan, we analyzed the occlusion, and they underwent a minor enameloplasty, where the tooth enameloplasty or the coronoplasty was done in microns, and polishing of the occlusal surface was done, and the masticatory muscle function was simultaneously checked with the EMG. After this, then the JVA, that is 1 minute non-invasive procedure that requires patient to open and close the mouth six times with the headset was done. Institutional ethical committee was provided with an formal approval process. The following inclusion and exclusion criteria were followed. Basically, the exclusion criteria is there was no treatment for the temporomandibular disorders was done priorly to these patients, and the patient underwent T-scan 3 digital occlusal analysis, which quantified their closure forces against the time and measured the right and left exclusive disclusion time, and pre-treatment disclusion time was evaluated. Next, the full range of opening from centric occlusion to maximum opening posterior and any lateral deflections values were also measured in millimeter and were entered in the computer biopad. The presence of lateral deflection more than 4 was excluded from the study. The joint vibration analysis was used to record the vibrations both on the right and the left side of the TMJ simultaneously, and this was done utilizing a metronome to pace the rate of opening and closing. So at least 6 times the cycle of 1.5 second per cycle were recorded for each patient. The patients were instructed to make a light tooth contact while closing, and um, conclusive evidence of complete closure. The patient underwent these measurement of disclusion time before the treatment, and occlusal adjustment was also carried out. So once the occlusal adjustment was done, once the disclusion time was achieved of 0.4 second, each patient, after analyzing the pre-treatment disclusion time data, enameloplasty was completed. Either in some cases, either it was reduction therapy or addition therapy. Some patients we had to add little bit of composite on the canines to build up the canine guidance. So at this point of time, the T-scan recordings were taken, and ICAGD corrections were made to correct the occlusion. So here, after this treatment, the patients were asked to inform the clinicians if the occlusion is felt pressurized, or if there is any rocking, or if the occlusion seemed to be feel good on both right and the left side, or if they are experiencing any apparent temporal, facial, or neck pain, or if there is any tension in the face, or they felt blocked while gliding, that is a restriction in the movement of the joint. In case if anything subjectively was seen, corrections were done, and additionally each subjects were specifically asked to see the new occlusion appear to feel how noticeably lighter it was, the desired therapeutic occlusal field change for the subject to experience resultant from the corrected ICAGD coronoplasty. The lighter field indicates that the posterior teeth no longer excessively or frictionally engage the involved teeth and compress the periodontal ligament. The mechanoreceptors, as often as for long time in pre-ICAGD conditions. Now, it allowed for a lessened muscle activity, lower lactic acid production, and which increases the availability of oxygen for improved muscular function and muscle tissue healing, and reduced muscular symptoms. Now, each patient then was instructed to observe for the noted physical changes resulted from the treatment, muscle relaxation, decreased muscle pain, and shortened DTR began to physiologically lessen the symptoms. Then again, after this treatment, the patient underwent the JVA analysis, where the headset was placed, and you can see here the joint vibration analysis was evaluated. From the vibration, now this picture shows a multi-bite analysis before DTR therapy, where you can see the red columns of heavier contact, which was then reduced, and this is the pre-treatment JVA records, where we can see the discrepancy in the frequency, and this is the corrected DTR picture, where all the red columns were reduced by doing a good ICAGD procedures, and this is improved joint after the ICAGD treatment, which we can see immediately for the better effect. So from the vibrations, uh, data, each subject with 6 parameters were calculated within the BioPact program. That is the total integral less than 300 hertz, integral more than 300 hertz, peak amplitude, peak frequency, and medium frequency. Now, these peak amplitude, it is basically tend to indicate the audibility of the joint noise. Peak frequency usually is a parameter has a relationship to the chronicity of the derangements, and integral, it is basically the distribution of the most affected area by the degenerative changes. Integral less than 300 hertz is basically the frequency distribution in most affected by displacements. Total integrated is the measure to for the total vibration intensity. So all these parameters were compared, and the mean range of motion post CTR increased from 43.4 mm to 47.4 mm after ICAGD treatment. So all 6 parameters had nearly equal variances and not significantly different between the sites. So therefore, it was decided to use the common statistical tactics of pooling left and right side mean value for each JVA parameters. Now, 4 of the 6 JVA parameters, that is a total integral more than 300, peak amplitude, peak frequency, were significantly reduced after ICAGD. Only the integral above 300 Hertz ratio were not significantly changed. Now, this test determined that the Piper classification order of risk assessment mean value significantly decreased for both left and right joint, measured reduction in the joint vibration intensities after ICAGD results in a significant uh, bilateral lessening of the severity of the dysfunction. So, disclusion time reduction therapy using properly performed DTR therapy is a good treatment option for temporomandibular disorders and was quite successful among the 52 subjects which were treated in this study. Now, this results of this investigation also indicated that many mildly pathologic TMJ joint conditions, as observed in this group of patients, improved after their prolonged disclusion times were shortened. As this study was attempted using a JVA to assess vibration pattern changes resultant from the computer guided occlusal therapy, these results cannot directly support or refute the findings of the earlier study, but the patient reflected changes towards the improved temporomandibular joint function that appear similar to those observed in normal subjects when measured by JVA, which is done. The significant changes, to conclude, the significant changes in JVA parameter illustrate the ICAGD brought a very significant change to the patient joint structural vibration. All result indicated there was a less aberrant disc movement, which is indicative of definitive improvement in the disc function and during mandibular motion. Reduced muscular activity improved the patient joint function in opening and closing pathways. Being less disturbed allowed for the free and smoother joint capsule motion on top of the condyle, and it is also possible that decreased disclosure time resulted in the decreased sympathetic tone with subsequent reduction in the dystonia of the lateral pterygoid muscle, lessening tension in both disc and the capsule. So every TMJ is unique and no JVA records will be exactly the same. While certain parameters have general characteristics, there will be always exceptions. Therefore, it can be concluded that temporomandibular joint vibration analysis using JVA allows detection of the early and the latent dysfunction of the temporomandibular joint disorders. The advent of this disclusion time reduction therapy is potentially new direction in the treatment of TMD using properly performed DTR therapy, and is shown to significantly improve in the signs and symptoms of temporomandibular disorders. These are my references. Thank you.
Thank you, Dr. Shweta, for your presentation. So,
Thank you.
anyone have any questions? So, no questions. Thank you once again for your presence and presentation.
Yeah, thank you so much.
Yeah. So, by this, we conclude our day one webinar for pain research and management. And thank you all for making it a successful one. And I hope everyone will attend the tomorrow sessions too and make it a successful also. Thank you and have a nice day. We'll meet you tomorrow.
Yeah, thank you.
Thank you, Ms.